Sunil sir, good evening. You're muted.
Hello.
Hello, sir.
Hello. So nice to see you, Dilip.
Thank you, sir.
Happy you are
Same here.
organizing. Happy you are organizing this program. So nice, dear.
Anup sir is the main organizer.
Sorry.
Anup sir is the main person.
Anup from Sabdajan?
Yes, sir. Yes, sir.
Okay, okay.
Good evening,
Is
sir.
he? He is.
Good evening, friends.
Okay.
Hi, Sunil. How are you?
I'm fine. Hello.
I'm
Hello.
Anil Varshne here.
Oh,
Nice to see you.
So nice to see you, Anil, too.
It's great. This webinars may give us an opportunity to meet each other. At
Oh,
least on
yes.
WebEx.
Oh, yes, yes. It's
Great.
so nice.
How things are at Oslo?
Oh, now it's cold. Conditions are well controlled. And COVID, I mean, that is well controlled. Population is less. People follow the rules, educated. So that makes a lot of difference.
Yeah, I think that is the key word.
Yes. So it's such a nice thing that I just saw, I got the message. I thought, oh, Saturday I'm free. I will listen to all the greats who will be discussing the topic. And it's always worthwhile, Anil.
Yeah. We will also have your comments if possible. It's a very tight program, so I don't know what the organizers have kept for you.
Don't worry, Anil. It's always you listen also. That is all.
Yes,
It's always a learning
I
thing.
always listen to all the webinars.
Yeah.
Because it gives us an opportunity to rejuvenate ourselves.
Hello,
Definitely.
hello.
Good evening,
Hello,
Anand
sir.
sir.
Good evening.
Anish sir.
Good evening, everybody.
Hello,
Good
hello, how are
evening.
you?
Good evening, sir.
Good evening, sir.
Nice to see you always in action.
Hello. Yeah, OT is running, OPD is running. What can we do?
Yes.
Hello, Anant. Nice to see
Hello,
you.
how are you? Seeing you
I'm
after
fine.
long time. Yeah.
It's a long time, Anant. Long time.
So how is life in Sweden?
No, I'm in Oslo, Norway.
Oh, sorry. So
Yeah,
how is life
yes.
in Oslo?
It's very good. It's
I could
now
see Oslo
cold.
behind it. I just missed it. I could
Oh.
see Oslo behind it. Just missed it.
It's so nice that we will be able to listen to you all discussing the topic or something like that. It's such a nice way now.
And for those of you who don't know, Dr. Sunil Kumar Gupta belongs to a place very near Faridabad. And I'm sure you all know about Vallabhgarh. That is where he was brought up. And he still has very, very warm memories, I'm sure, of that place. And whenever we meet, we always talk about Vallabhgarh. It's such a pleasure, talking about India and Indian cities. And he obviously has a lot of emotional connect. Despite being away, his heart is very, very much present here.
Hello, Amlesh. So nice to see you.
Thank you so much. Good evening, sir. Good evening.
Good evening,
Professor
sir.
Gupta has also joined. So I
Good
can
evening,
see a lot of.
Good evening, sir.
Very good evening, sir.
Very well.
We have
Yes,
5
good evening,
minutes to
Dr.
go.
Gupta, sir.
We have 5 minutes to go.
We have 5 minutes to go.
I would request everyone to log in with their own name so that we can identify.
Anyway.
Good evening, sir. Good evening, Dr. N.P. Gupta. So nice to see you.
I still remember you. Don't worry. 40 years probably now.
Yes, sir. Yes, sir. So nice to see you.
Good evening, sir. So you are back to India or still in UK?
No,
Yeah.
I'm in Norway, sir.
Norway.
Norway. Yeah, I
Yeah.
remember.
Yeah.
Good. Happy there?
Oh, yes, sir. I'm now permanently settled here. And now
Good.
it's almost 21 years for me in Norway.
Okay.
Nitin, we can see the slide.
Make it full screen, Nitin. Yes, now it's better.
And you need to change your name there. We can see your face, but we cannot hear you.
Dr. Low.
Hi.
Hi. So
Hi.
can you please pronounce your name so that when I introduce you, then I don't make any mistake.
Okay, I'm Dr. Low Kalen.
Okay. Okay.
Dr. F.P. Yadav.
Where are you in Hong Kong?
Hello, Sir.
I'm
Congratulations.
sir. Namaskar.
Namaskar, sir. Namaskar.
मैंने कहा heartiest congratulations to your son.
Thank you, sir. Thank you, sir.
I was going to call you today. I thought I'll speak to you personally. So I just
Thank you,
called
sir. Thank you.
Sir, great news भी बता दीजिए.
His son has qualified the international exam from Singapore group actually, you know. So that news was there in the North Zone meeting.
Okay. अच्छा. Good. Congratulations.
Congratulations, sir. Congrats.
Congratulations. Very good.
Congrats, sir, for the great achievement of your son.
Thank you, sir.
Thank you.
Oh God.
Eh?
Good evening, sir.
Eh?
Sir, good evening.
Good evening,
Good
everybody.
evening, Rajiv. Good evening.
Good evening to everybody.
So, good evening.
Hello Raju, good evening.
We have 3 minutes to go, sir, now.
Okay. Maybe we can start 1 minute early also because the program is very long. And so initially we'll have the introductions and all the people. I think we can start.
Now only update.
Okay. Let us begin. Welcome everybody to this international review of the abstracts of EAU. So the really hot ones directly from the oven, they have been selected. So 33 abstracts have been selected and they are going to be presented by the young energetic consultants, and they will be discussing, and then the expert comments would be provided by the senior consultants. And because this is a North Zone activity, and as the North Zone activity, the president and secretary, Dr. Anant Kumar and Dr. T.P. Rajiv, of the president and secretary of Urology Society of India, they are special invitees, and they will be addressing all of us in the initial part of the program. We have we are going to have very active participation by 3 of our international faculty members. Dr. Lola Kun from Hong Kong is already there, and he has been participating in the discussions. You all can see him smiling and happy to be part of this. I'm sure happy to be part of this. And we welcome Dr. Amit Chakravarti also. I can't see Dr. Amit Chakravarti. He's from Northern Alabama in USA. And Dr. Anil Shrestha is from Veer Hospital in Kathmandu in Nepal. I can't see him also. I'm sure he also must be here. The occasion is graced by a lot of past presidents of Urology Society of India. Professor N.P. Gupta, I would say the omnipresent man for all these academic activities, the ex-chairman of our Department of Urology, and everybody knows him. And the other past presidents, Dr. Madhu Agarwal, Dr. Rajiv Sood, the past presidents of North Zone Chapter, Urology Society of India, Dr. S.P. Yadav, Dr. Anil Varshne, Dr. Anish Srivastav, Dr. S.K. Pal. I hope I have not missed anybody. And there are a lot of young people who are going to, the coordinator for today's activities is Dr. Dilip Mishra from Agra. And I would now hand over to Dr. Anup, who will carry the proceedings, and we'll invite Dr. Anant Kumar and others. Thank you, everybody. Thank you.
Thank you, Dr. Seth, sir. So now we'll invite USI President Dr. Anant Kumar, sir, to give his welcome address. Dr. Anant Kumar, sir.
Good afternoon to everybody, and I welcome you all to this wonderful educational activities. And you know that EAU this time was completely virtual, and some of us tried to attend it, but because it was working days, so some of the part we could attend, some we could not attend. So at least this is a wonderful activity to update us whatever we have missed it. But my only grudge is, again, it is starting 5 o'clock, and it is still a working time for some of us, and we are still busy. So we may be able to attend some of it, may not be completely, but most of the people will take the advantage of attending this webinar, and where the important paper of endourology will be presented. You know, endourology is not only bread and butter, it is almost, most of the urology is done by around 50-60% of our urology members. And it is the endourology is a very busy part of their practice, and it is very important for them to update in this aspect from the latest publication and latest research and presentation. And with that, I would, as a member of USI President, I wish a good health of everybody. Because we are passing through a difficult pandemic time. There is a good news nowadays that number of cases are going down, but we are also worried about this festival season, which may not bring the wave back, because as the wave is coming back in Europe and USA. But let's hope, our finger crossed. So my request to all of my members to stay safe, don't lower your guard, so that you remain healthy and serve the humanity. With this, I welcome you all again to this wonderful webinar, and I hope this will be a very useful academic activity for all of us. Thank you very much. Back to Anup.
Thank you very much, sir, for your kind words. And I will request now our USI Honorary Secretary, Dr. Rajiv TP, sir, to please give his opening remarks.
Good evening, respected President, Urological Society of India, Professor Anant Kumar, President, North Zone Chapter, Urological Society of India, Professor Amlesh Sheth, Secretary, North Zone Chapter, Urological Society of India, Dr. Anup Kumar, past presidents of the Urological Society of India, international faculties, Dr. Amit Chakravarti from USA, Loka Lum from Hong Kong, and Dr. Anil Shrestha from Nepal, and eminent national faculties. Greetings from Urological Society of India, and I, on behalf of the Council of Urological Society of India, welcome all of you to this program. It's a great initiative by the North Zone Chapter Urological Society of India. In fact, I think this is the second international review on the best of EAU abstracts, this time on endourology. And the moderators, Dr. Dilip Mishra and Dr. Tanuj Balpatia, have, as the president of North Zone Chapter, said, out of the 35 abstracts in the best abstracts in endourology, they have compiled an interesting program wherein our eminent national and international faculties will be discussing on these abstracts and critically reviewing it. This will be a very interesting academic event brought out by the North Zone Chapter of Urological Society of India. With these few words, I welcome you all once again to this program and wish this program all great success. Thank you all once again.
Thank you very much, Dr. Rajiv, sir. On the behalf of NZUSI Council, I would like to again tell that NZUSI is always willing to have international collaborations on most of our conferences, webinars, and in this conference also we have Dr. Amit Chakravarti has joined now from US, and then we have Dr. Loka Lun and Dr. Anil Shrestha, and then we have our seniors, Professor N.P. Gupta, Dr. Rajiv Sood has also joined, and all other seniors, they have joined along with our young dynamic colleagues, they have joined. And in this program, we have given chance to our young dynamic colleagues so that they can show their talent, and our seniors are going to give their expert comments. So we are again showing it live on Zoom and various other platforms. And now I will going to hand over this to the coordinators of this today's event, Dr. Dilip Mishra and Dr. Tanuj Pal Bhatia, and they are going to tell us the overview of the program, and then they are going to start with the first session. So over to Dr. Dilip Mishra and Dr. Tanuj Pal Bhatia now.
Good evening, seniors, teachers, and friends. I will not talk too much. I will just give a brief overview. First of all, I would like to thank Anup sir and our Northern USI for giving us this opportunity to hold this program. It's a great concept to have selected the abstract of EAU and to be presented and discussed. We went through more than 300 abstracts to select these 2 abstracts, which are of very good quality. Now we will have one speaker who will present 2 to 3 abstracts in 8 to 9 minutes
patient का
time.
क्या हाल है? Prostate biopsy वाला.
And then the speakers will present the abstract as it is, followed by their comments or any literature review. Each speaker has been assigned to an expert. The same expert will start the critical comments for the one speaker, followed by the other experts who will present their comments after the main expert. This is done just to save a little bit of time. And then the moderator will keep a tab of time and other questions being asked by the viewers. So whatever questions will be asked by the viewers or other experts, we will be presenting to the experts. So that's a brief overview for the whole program. And now I would hand over the proceedings to Tanuj to start the sessions. Tanuj, over to you.
Good evening, everyone. Thank you so much, Dr. Amlesh, Dr. Arup, and Northern USI for this opportunity to convene the prostate section of the program today. As Dr. Dilip has already given an overview how we are going to go about the program, the prostate section basically we have divided into a technology session and outcome session. So we will be starting with the technology session first, and I would like to invite the experts for the session, Dr. N.P. Gupta sir, Dr. Amit Chakravarti sir, Dr. Loka Lun, and Dr. Anshuman Agarwal sir. And we will be starting by first talk from Dr. Umesh Sharma.
Good evening, all of you. Am I audible?
Yes. Yes, you're audible. Please share your screen, Dr. Umesh.
Okay, I am sharing. So, hope my screen is visible.
Yes, clearly visible.
Yes, it is.
At the outset, I would like to thank Northern USI for giving me this opportunity, and especially Dr. Tanuj for giving me this opportunity. And I have been given 2 endourological abstracts in the subset of basically prostate. So my first abstract, prospective randomized study compares the safety and efficacy of holmium laser enucleation of prostate versus bipolar transurethral resection of prostate for management of benign prostatic enlargement. This is a randomized control trial, and this has been published in European Urology, and it is being from the Egypt. So basically, the literature is still lacking between the holmium laser enucleation as well as the bipolar TURP. With the advent of this newer technology, the gap between the holmium laser HOLEP versus bipolar TURP has been narrowed down. And right now, there is no current literature which is sufficient enough to compare the efficacy and safety of these 2 procedures in a randomized and prospective way, especially in a large prostates. So study design, it's a 2-year study, and the eligibility criteria is the lower urinary tract due to the benign prostatic enlargements. And here they have taken the glands of more than 80 grams. They have been divided into 1:1, and total 60 patients were recruited. Group 1 were HOLEP and group 2 were TURP. Pre-operative assessments were done in the form of IPSS, PSA, transrectal ultrasonography, PVR, and uroflowmetry. Post-operative assessment were done in operative time. In the form of operative time, they resected tissue weight, blood transfusion, hemoglobin loss, time of voiding, and hospital stay. This post-operative assessment at the 1 month, 6 month, and 12 months have been done also, which shows about the various parameters. So finally, I'm coming to the result. There is not much in the paper. The result was, it's a clear-cut result which have been already shown by the various papers also. In group 1, the irrigating fluid volume was comparable in both the groups. Hemoglobin loss was significant, and it was lesser in group 1, which is HOLEP, as compared to group 2 bipolar TURP. Catheterization time was 1.8 in HOLEP versus it is 1.6 in group 2. Hospital stay is lesser in group 1 versus in group 2, where it is 4 on an average 4 day. Resected volume is greater. It is 89 plus minus 14.4 gram in group 1 versus it is 74.4 in group 2. Rest of the parameters, the post-operative parameters, which were assessed at 12 months in the form of IPSS, PVR, and Qmax, they were significantly improved in HOLEP group. So to conclude is that HOLEP is more effective than bipolar TURP in resecting prostate of more than 120 gram. Since they have one subset where they have compared the bipolar TURP, in which they have resected they have taken only more than 100 gram of prostate. In that subset of this study, the holmium results were better as compared to bipolar TURP. But when we compare the prostate in the range of 80 to 100 gram, the results were equally good in both the hands. For a smaller prostate size, the results were comparable, and complication rates were not significantly different in both the groups. When I searched the literature, we found a similar study which was done by our own Dr. Professor N.P. Gupta sir, and it was published in Indian Journal of Urology. It was a review article, systematic review article, where they have taken literatures and retrospectively analyzed the bipolar TURP, HOLEP, and PVP, and they came with a result that both three procedures have equivalent outcome for the larger prostate. For extremely large glands, which are around 150 grams, HOLEP is very efficacious endoscopic alternative to open prostatectomy and has proven long-term results over more than a decade. So it is very much similar to this article. Most of the studies in the literature, they are all retrospective, and they have compared holmium with bipolar TURP or holmium with monopolar TURP. But such a study in which mainly HOLEP is compared with bipolar TURP, especially in a large gland, is limited. This is also one of the study. It's a randomized study, but again, they have taken the smaller gland, means the glands are not more than 60 grams. And here also you can see that both HOLEP and the bipolar TURP are effective in treating the patient with lower urinary tract symptoms due to BPH. However, the longer operating time, which is obviously in the HOLEP, and that all depends on the experience to experience, which goes down as the doctor become experienced. The steep learning curve is there in the HOLEP enucleation technique, as well as higher expenses of HOLEP are in the favor of higher expenses was found in HOLEP. My next article, it's a Cochrane systemic review, bipolar versus monopolar transurethral resection of prostate for lower urinary tract symptoms secondary to the benign prostatic obstruction. So in spite of the accumulation of evidence over the last decade, comparing the monopolar versus bipolar in the management of lower urinary tract symptoms, there remains still uncertainty regarding the differences in the patient outcome between these surgical methods. So this is a very good Cochrane systemic review which compare the effect of bipolar and monopolar TURP. Study design is a very extensive and exhaustive study design. They have taken all the possible methods of search methods. They included the central, midline, Embase, clinical trials database, PubMed, WHO, ICTRP, and they have not taken any language restrictions. Out of this, the selection criteria were mainly the randomized control trials, monopolar versus bipolar, and age should be more than 18 years, and this way. Overall, 59 RCTs were selected and 8,924 participants were included. Mean age of the these all result came out to be in 59 to 74 years, and prostate volume include all the spectrum of from moderate to large size. This was the this is the outcome of this study. It was assessed at 12 months. So the first one is an IPSS at 12 months. Total 16 RCTs were chosen. Level of evidence of these were moderate, and absolute effect in compared to the monopolar TURP is 6.4. At the end of 12 month, IPSS score was 6.4 with monopolar TURP. As for bipolar TURP, the mean difference was 0.2 for lower. So the bipolar TURP has an edge, but the overall clinical significance is not. Health-related quality of life at 12 months, 11 RCTs were chosen. And again, with monopolar, it was 1.7, while for bipolar, it was mean difference was 0.12 lower. TUR syndrome, as we know, it is more with the bipolar, with the monopolar TURP. So here 44 RCTs were compared. The relative risk was 0.17. That means if you compare, if in the monopolar, there were 24 per 1,000 and mean number of events on 1.8, while in bipolar TURP, it was 20 fewer cases per 1,000. So bipolar TURP has an edge. When we take the urinary incontinence at the 12 months of, then 4 RCTs were chosen, and in this the evidence was low. And in case of monopolar, 5 per 1,000 were the number of events where urinary incontinence was found, while here in bipolar TURP, there were 4 fewer per 1,000 cases. Blood transfusion, again, they were fewer in cases of bipolar TURP, 28 fewer cases as compared to monopolar, where 48 per 1,000 blood transfusions were done. If we come for the re-TURP status, again 6 RCTs were chosen, and the status in case of bipolar TURP, 1 more cases per 1,000, and in case of monopolar, it was 34 per 1,000 cases. Erectile function at 12 months was at 12 months, the erectile function was higher in case of bipolar TURP versus in monopolar, it was 19.2. So finally, to conclude, bipolar TURP and monopolar TURP improve urological symptoms to a similar degree. As we see the IPSS score, they were similar in both the groups. Bipolar TURP probably reduces both TUR syndrome and blood transfusion. The impact on erectile dysfunction is probably similar for both the surgical modalities, and with the level of evidence which is available, all the level of evidence, most of the RCTs were moderate. It have given a clear-cut consensus that there is no need for further RCTs comparing the bipolar TURP and the monopolar TURP. Thank you.
Thank you, Dr. Umesh. May I invite Dr. NP Gupta, sir, for expert comments, please?
Thank you, Umesh, for presentation of both these abstracts. I will start with the second first. I have seen the transition from the monopolar to bipolar and all, and I have experience of my personal experience of all these technologies. So the comment which I want to make is that the safety of the patient is more important. And if you see between monopolar and bipolar, if you are doing a small gland less than 70 grams, that doesn't make any difference. But if you are resecting for a long time, then certainly bipolar has the advantage of less hyponatremia, and the other things are more or less equal. but safety point of view, bipolar is better if you are doing a large gland. Comparing between the bipolar TURP and HOLEP, as you have already mentioned, that if a gland is very large, more than 120 grams, then HOLEP has a edge. Otherwise, both give rise to the same kind of output. But the main thing which I want to highlight here is the surgeon's expertise and experience is more important than choosing whether you are doing bipolar or you are doing the HOLEP. A surgeon who is expert in HOLEP, he can do as good as in 70, 80 grams or 120 or 150 grams. Similarly, a surgeon who is expert in bipolar can do the same 70, 80 or 100 gram or 150 gram also safely. So the expertise of the surgeon, because these statics are good for presentation, but when it comes to the individual patient, surgeon has to think what best outcome he gives to that particular patient. Because I have seen that patient is going to come back to you, and if something goes wrong, he's going to catch hold of you only. He won't go to the aesthetics or something. So the personal experience and expertise is equally important. And I request my other experts if they like to make any comment.
Thank you, sir.
Amit, you like to say anything or should we go ahead? You agree with me? Please unmute yourself. Unmute, Amit.
Thank you very much. Thank you very much, Dr. Gupta, and thank you very much for inviting me over to this beautiful conference. It's early in the morning here in USA, but excited to be here. And yeah, the very well presented papers, and these are the comments which Dr. Gupta made were very, very appropriate. HOLEP, obviously, and I'm going to discuss this about in the next talk, but HOLEP, as you know, has a steep learning curve. We don't have to kid ourselves that big glands can be attacked, can be obviously taken care of by HOLEP, but it has to have extra equipment and also has to have a fair degree of expertise in that subject. And if you can achieve that, you can actually do very large glands quite effectively, and we've seen that happen. So yeah, congratulations.
Someone, you like to make any comment?
Yes,
or you agree with us? Yeah.
Yes. So I basically agree with whatever you have said, sir. But over a period of years, there is one more important thing which I realized. We always talk of surgeon's experience. We always talk of prostate size. We don't see what is the patient profile. So I think patient profile is very important. And nowadays I realized that if you do a TURP using a 22 French resectoscope, or if you do a TURP using a 24 French resectoscope, you see the beauty of TURP is that you can manipulate the size of the scope as per the size of the urethra. Right, sir? So the only problem that I face with bipolar TURP or monopolar TURP or HOLEP is incidence of urethral stricture. That is the only thing that bothers me. You have taken care of one obstruction and you have given the patient other obstruction. So I think we must look at minimizing the size of the instruments, and whatever modality, we are all trained in doing monopolar, bipolar, HOLEP, green light laser, whatever. I think the smallest size of the instrument that you use at the end of the day, in my practice, I think that is what matters. Most prostates that we get are about 100 grams, 120 grams. A successful, good expert resectionist will take care of that. But I think using a smaller instrument, staying in the urethra for the smallest possible of time is what matters at the end of the day.
Thank you, Anshuman. Yeah, anyone else like to make any comment? Otherwise, we'll go to the next topic. Okay, thank you very much. Thank you.
Dr. Lowe wants to comment.
Lowe want to make any comment?
Yeah, in my center, we do a lot of HOLEP. Found that I agree with Dr. Ahmed that the learning curve is a little bit steep, at least 30 cases to start with. So I would suggest to have start with some small prostate at around 50 grams, not a very big prostate. Otherwise, you will have very bloody situation. Sometimes you get blood transfusion. But once you get the correct plane and also get the experience, then I think you can increase the size of the prostate. This is my comment.
Okay, thank you. Thank you, your comment. Dr. Tanuj, go back to you.
Sir. So may I invite Dr. Rahul Gupta for the next talk, please? Dr. Rahul. Rahul, are you there? Sir, if you permit, can we move to the next talk? I'll get in touch with Dr. Rahul. His phone is So may I invite Dr. Sandeep Kumar for his talk on novel technologies, please? And we'll come back to Dr. Rahul after Dr. Sandeep's talk. Dr. Sandeep, we can't hear you. I think you're mute.
Hello. Am I audible?
We can see your screen, Dr. Sandeep, but can't hear you. Please unmute yourself, Dr. Sandeep. Just give me a second. Dr. Sandeep, we can't hear you. Yeah, we can see you now.
Am I audible?
Yeah, if you can speak a little bit more louder, you'll be more audible.
Okay, sir. Good evening, everybody. We are going today to discuss 3 studies involving the novel technology.
Little bit more loud, please, Dr. Sandeep. Sorry to interrupt.
As we all know, acute intention is complicating of progressive BPH.
Sandeep, can you use your earphone, please? That will make the audio much clear.
Is it better, sir?
Chalo beta.
You can try and keep the mic near your mouth and maybe speak, then it will be better, I think.
As we all know that acute infection is a known complication of progressive BPH, which
Yes,
is initially managed with medical treatment, but failing to which leads to various invasive surgical procedures, which have their own associated morbidity and long-term complications. This device, prostatic urethral lift, actually a permanent implant which mechanically opens the prostatic fossa. The objective of this study was to assess safety and feasibility of the prostatic urethral lift in acute urinary retention patients due to BPH, and secondary objective was comparing these outcomes to the randomized controlled trial with non-AUR population, that is lift and BPH trials.
Left.
So a prospective multicentric study was conducted in which patients with BPH with retention were included with having prostatic volume less than 100 cc and at least one failed trial on alpha blocker without catheter. Various outcomes were measured using various scoring systems like IPSS, BPH impact index, sexual health inventory for the men, and various
Make it full
biodynamic.
screen, please. No, Sandeep?
Yes, sir.
Make it full screen.
Pardon me, sir. And it was compared with the lift and BPH-6 studies.
Please make the presentation full screen, Dr. Sandeep. Go to slideshow icon below. In the PowerPoint, yeah.
Okay, sir. So patients were found significantly older and prostate was larger than the lift study. 58% patient could void successfully without catheter at third day, and 73% were catheter free at 12 months. Most adverse events were mild to moderate, which resolved within 2 weeks. Sexual functions were either improved or consistent throughout follow-up, which were similar with the LIFT study. 81% patients were much or very much better at 12 months. 82% subjects stopped taking alpha blocker altogether, and 83% recommended the procedure. 87% patients returned to the normal activity in 8.5 days. IPSS score was consistent with the LIFT, but quality of life outcome was superior to the LIFT study. We can see this in tabular form that quality of life is significantly better in Pulsar study in comparison to the LIFT study. So it was concluded that this device could safely and rapidly restore the normal wiring in acute urinary retention patients due to BPH while preserving the erectile function. And it can have a profound impact on the acute urinary retention patient life. There were two studies with which this was compared, BPH-6 study and LIFT study. Both were prospective multicentric RCT with different follow-up and slightly different comparison. BPH-6 study, prostatic urethral lift, was compared with the TURP, and it was found that IPSS and Qmax in the TURP arm were superior, but continence was significantly compromised at 3-month interval, while prostatic urethral lift resulted in superior quality of recovery and ejaculatory function preservation. In LIFT study, prostatic urethral lift was compared with the SAM control with a longer follow-up, that is 5 years, and it was found that it offered rapid improvement in symptom, quality of life, and flow rate with preservation of both erectile and ejaculatory function. Next study is Everest 1, which involves Optilume BPH catheter system. Aim of this study was to evaluate the efficacy and safety of this system in LUTS patient due to BPH. This was the first time that paclitaxel was used to coat a prostatic balloon for the treatment of BPH. So a prospective non-randomized study was done. Optilume BPH catheter system basically consists of two investigational catheters, includes prostatic pre-dilatation catheter and prostatic dilatation drug-coated balloon catheter. This system was used to perform a anterior commissurotomy of the prostate in 80 patients transurethral. The inclusion criteria was LUTS patient with IPSS more than 13 secondary to BPH, Qmax more than 5 and less than 15, PVR less than 250 ml, prostatic volume up to 80 gram, and prostatic urethra 35 to 55 mm in length. Last two parameters were measured using transrectal ultrasound. Patients who were having history of urethral stricture, bladder neck contracture, use of any alpha blocker within 3 weeks or 5-alpha reductase within 6 months, or any suspicion of malignancy or confirmed cases of malignancy were excluded from this study. Similarly, patients who were unwilling to use protected sex for 1 month were also excluded from this study. Primary endpoint was defined as IPSS improvement of 40% or more and any major complication. Secondary endpoint was defined as mean decrease of IPSS at each follow-up and change in Qmax, change in PVR, and percentage of subject with IPSS improvement of 30, 40, 50 or more than 75%. So primary endpoint at 3 months was met with 82% of the subjects had IPSS improvement of 40% or more from the baseline, and 3% had major devices related complication of stress urinary incontinence. Average IPSS score improved from 22.3 to 7.9 at 1 year follow-up, and average Qmax increased from 10.9 ml per second to 18.4 ml per second. Both these improvements were found clinically meaningful. No significant effect on erectile function was found. This is a follow-up case with 2 years after using Optilume BPH catheter system. It was concluded that a significant subjective and objective improvement was found in LUTS patients secondary to BPH, and these data served as a gateway to pivotal role trial versus sham, which is now underway. But long-term efficacy and safety will determine the role of Optilume BPH catheter system as a therapeutic option. Third study is MT06 study, in which temporary implantable nitinol devices was used with 6-month follow-up. Aim of this study was to evaluate the functional and sexual outcome after treatment with this device. So symptomatic patients were included with IPSS more than 10, Qmax less than 12, and prostatic volume less than 120 ml in this prospective multicentric study. Patients with large median lobe, history of prosthetic surgery, neurological dysfunction, and UTI were excluded. This device was implanted using cystoscopy under IV sedation and removed 5 to 7 days later under local anesthesia. Post-operative pain score and complications were recorded. Preservation of urinary continence and sexual and ejaculatory function were assessed according to various scoring systems, and post-operative IPSS quality of life and QMAX were also assessed at various intervals. So 70 patients were enrolled.
Can I request you to go a little faster?
Okay, sir.
Because we are running short of time.
70 patients were included. No intraoperative complication was observed. Only 5% patients presented with a Clavian 3 or more complications. On average, patient returned to daily life after 4 days, and significant improvement from baseline were recorded in IPSS, quality of life, and peak flow in response to this treatment, while sexual and urinary continence were preserved. You can see this in tabular form. And so it was concluded that it's a well-tolerated, minimally invasive treatment with a rapid recovery and return to the daily life with preservation of sexual function and urinary continence with 6-month follow-up. A similar study was performed with similar results with longer follow-up, that is 3-year follow-up, which was published in August 2020. Thank you.
Thank you, Dr. Sandeep. May I invite Dr. Anshuman Agarwal, sir, for the expert comments, please?
Thank you, Anuj, and thank you, Sandeep, for enlightening us with the newer developments in the field of BPH treatment. So, as we were discussing in the previous presentations, I think we are still far away from the most ideal treatment for BPH, because all that we have so far is invasive, requires anesthesia, is fraught with complications. So, all three of these are aiming at, minimally invasive treatments for BPH, where, probably not even a single drop of blood is lost. We can take care of high-risk patients who are not fit for, surgeries like TURP or HOLEP or green light. So, regarding the prostatic and all these three treatments probably are still not available in India. Last time I tried to find out a memocath for a prostate patient, but it was not available. So, I'm pretty sure that all these Optilume and iTind and prostatic urethral lift are still. I had a word with Tanuj also, and prostatic urethral lift is still not available. But you see the emphasis, you have to see the demography of the patients, that is being treated using these techniques. In India, most patients want a cost-effective treatment wherein you have to give them a treatment which is durable for 10 years, 15 years, and they don't want to go for a repeat treatment. All these three treatment modalities have got some limitation or the other, where whether there's a large median lobe, or whether there's a bladder neck contracture, whether there's the prostatic size, some size limitation, and some limitation to the treatment do exist. But I think we can definitely find suitable candidates. They all have a follow-up of more than a year and showing promising result. In fact, Optilume, the cystoscopic picture that you show, it looks like a TURP, post-TURP kind of a prostate. So I think these are very promising techniques, with minimum incidence of post-operative complications. And the most important point that is highlighted in all three studies is the sexual performance score. So that is the most important. I mean, I don't think that in our population, especially the rural population, the patients are so much concerned about, the sexual performance status and all these things. And what they want is a more durable, treatment form, which is not probably to be repeated ever in their life. I would like to invite my co-panelists, Dr. Gupta, Dr. Amit, and Dr. Kohn, if they have any comments to make on this.
I like to only make a comment that when you talk of sexual dysfunction, I think so retrograde ejaculation, that is one of the main concerns to the patients, and I'm getting a lot of requests nowadays that they want to preserve their ejaculatory dysfunction. So these are the candidates where one can try urolift, but it is only for a small gland and not the median lobe. So without median lobe, if somebody has only lateral lobe enlargement, then one can try urolift. I have a patient here in Delhi only who went to UK to got a urolift, and he's happy, but his gland was only 25 grams. So small prostate is good. Large prostate, we have no experience.
So having done all these minimally invasive procedures, urolift can be done in the office and can be done under local anesthesia. Like Dr. Gupta said, that it is for smaller glands. There's no minimum size. but the maximum size you cannot go about 80. Though traditionally we do not do it for median lobes, we are trying on few selected median lobes. That's not in the literature. But one thing which AU guidelines actually tells you to do, one good thing about Eurolift is the Eurolift is the only one in the spectrum which says that that's got 0% retrograde ejaculation rate. Tuna microwaves had like a 2%. Resume also has that kind of amount, but Eurolift has 0. So if a patient is very, very concerned about retrograde ejaculation, Eurolift is the way to go because that's the only one which says it has got a 0 ejaculation rate. Most important thing which AU guidelines specifically say that you have to tell the patient that we don't have long-term data. You have to tell them that we don't know the long-term longevity. You have to discuss with the patient that this is a new kid on the block, and though initial results are promising, we don't know whether this will last forever. And this makes this is particularly significant in a place like India, where most of the people have to pay out of their pocket for these kind of procedures, and Eurolift actually is quite expensive, even in US standards, and that's something which needs to be kept in mind in an Indian scenario.
Yes, we have started Eurolift last year in our center. We found that the beauty of the Eurolift is that it's a very immediate effect. Actually, we just have widened the channel once you have the Eurolift. But the problem is that bear in mind there is the risk of erosion of the Eurolift. We have one case that the patient persistent complaint of dysuria 1 month after the Eurolift, and then cystoscopy found there's erosion of the Eurolift. That is very difficult to remove the foreign body of the Eurolift. So bear in mind there's a possible risk. At the same time, I agree with Dr. Ahmed that it's very expensive. Even in Hong Kong, the people will find that it's a really expensive one. So as compared with TRLP is, I would say it's more than 10 times expensive than in conventional TRP. So cost is also the factor. Thank you.
A little follow-up on Dr. Loh about the Eurolift exposure. It is actually I've had 2 patients who one of them actually healed without any intervention. Other one I had to do a TURP for exposure of this, and that's one of the things there. However, in my experience, doing a TURP and taking the Eurolift out is quite not that difficult because the sutures, its suture is not metal. Only the staple part of it, the middle part of it is metal. The inside, the one which goes in they are actually sutures, and so resection has not been that difficult. However, having said that, these patients are those younger patients who you do a Eurolift thinking that their symptoms are due to obstruction, but more often their symptoms may be a little bit more due to prostatitis. So patient selection is very important because these patients can be really, really very upset and very unhappy if you're doing a Eurolift procedure for a person who has more of a prostatitis symptoms rather than obstructive voiding symptoms.
Yes, thank you.
Thank you, sir. So we'll move on to the next session. Dr. Rahul is back with us. So we'll move on to the talk by Dr. Rahul Gupta, please. Please make it full screen, Dr. Rahul. Slideshow mode.
First of all, I'm sorry for being late. I hope my screen is visible.
Yes, Dr. Rahul.
And I am audible.
Yes, you are.
Good evening, everyone. At the outset, I'd like to thank the North Zone and Dr. Anup sir and Dr. Tanush for arranging such a nice program on a very relevant subject, which is BPH. And we may do anything, but we have to start our careers with the BPH. And taking back from what Dr. Anshuman said, a lot of things are not available in India, but I'm going to review the 2 things which are available in India, and all of them have, and we have seen those procedures in India itself. So what is the relevance of BPH? I'll just take a quick talk on that. It's the most common condition that ails men. Overall incidence rate of LUTS BPH is 15 per 1,000 man years, and ranging from 3 cases per 1,000 at the age of 45 to 49 years, which goes up to 38 cases per 1,000 at the age of 75 to 79 years. So a man of 46 years in the age group we are, the risk of development of LUTS BPH over coming years is 30 years is about 45%. And lifespan in India as of last year was about 70 years. And the Indian population, as we all know, is 1.2 billions. And of the men over the age of 65 years is 3.8 crores. So we can well imagine the number of men who will be suffering from LUTS and BPH. So the number of men with LUTS BPH in India is phenomenal. So I'm going to talk about Indian context, about what papers I'm going to review. And just the number makes BPH a very important issue. So the management options include a watchful waiting, medical therapy, and surgery. But whatever we do for the patients, the basic endpoint is that the therapy should be safe, ultimately, and help in improve the quality of life in these patients. The first paper which has been given to me to review is the HOLEP versus TURP. So both of the procedures are well-established procedures in urology circles and have been performed, and they've been there for more than 10 years. So there is no doubt about that, that both papers are good. And this paper was for the men with the prostate size of 50 cc's, and it comes from the Department of Urology, Munich, Germany, by Wetzhoffen T. The objective of the paper was to evaluate the perioperative parameters, the early functional outcomes, and the safety profile in a matched pair analysis of LUTS patients treated with HOLEP or transurethral resection of prostate. What they have not given is what type of TURP they have done, either mono or bipolar. That has not been mentioned in this article. That is one of the drawbacks of the study, which I feel it is a retrospective study. However, it is a matched pair analysis. Retrospectively, 2011 patients were men treated at the institutes were reviewed. The case charts were reviewed for the last 5 years from 2013 to 2017. And in the final analysis, around 200 patients were included. Of the number of the patients were almost equal for the HOLEP and the TURP. The prostate size was 50. Age and body mass index was match paired. Both the cohorts were compared for demographic parameters, clinical outcomes, and any adverse events according to the CD classification. In the results, what they've shown is that the perioperative assessment revealed a significantly higher tissue retrieval percentage for HOLEP vis-a-vis the TURP. This has been their observation, which is clinically significant, statistically significant. There was a shorter time for TURP by 7 minutes vis-a-vis HOLEP for a prostate of 50 cc. The median improvement in IPSS was much higher for HOLEP vis-a-vis TURP, and the peak flow rate, that is Qmax, increased after the HOLEP better vis-a-vis the TURP. This has been their observation, with an overall incidence of adverse events of 6% compared to 16% for the TURP versus HOLEP. So in all their parameters, the HOLEP was better. What adverse events were there, that has not been mentioned in their study. So what they concluded was that HOLEP is not only an attractive alternative for enucleation of larger prostates, but it must be considered for size independent technique. Like we are all taught in our initial days when laser came that HOLEP is for larger prostates because of the other benefits of the laser. But what they have concluded is even for small prostates, the laser can be used very effectively, rather giving better results vis-a-vis a standard TURP. The second abstract is the randomized trial of bipolar resection versus holmium, that is HOLEP, versus green light laser. Enucleation of prostate for treatment of large size benign prostatic obstruction, a 3 years outcome. This comes from Egypt, and it was presented by Alsan A. The basic purpose of the study was to assess the non-inferiority of the TURIS, that is a transurethral resection. And now they have in this paper, though they write enucleation of the prostate, since I don't have they have not published this article, so I believe that they have not done the transurethral enucleation using the bipolar. They most probably they've done a resection of the prostate. Green light laser they have used versus HOLEP for controlling of LUTS secondary to large size prostates. They have included inclusion criteria was 80 grams prostate with comparable 3 years retreatment rates. So eligible patients with the prostates more than 80 grams. HOLEP versus green light versus TURIS was compared. TURIS was done by Mormier's technique. So they've done a transurethral resection and not the enucleation. And the non-inferiority of retreatment was re-evaluated. So this is the result which they have shown. And in this case, they have shown that the statistically significance was there in the mean operative time, in which the HOLEP was much faster comparative to the green laser and the TURIS. So in the process, the HOLEP versus TURIS versus green laser, which took more time, mean operative, the amount of the tissue retrieved vis-a-vis the operative time taken was better for TURIS than for the green laser, than for the HOLEP. I don't know how they reached this conclusion, but this is what they have observed. Third was the mean hospital stay, which was this I would like to take a comment from Gupta sir also, what he's following and others are following in Delhi. Mean hospital day is just 1 day and 2 days for the TURP, which is quite acceptable. But what is important is mean time to catheter removal. They have removed the catheter on an average 1.5 days for the laser technique, and for TURIS they have kept it about 3 days. So this was their thing. And the hemoglobin drop was much higher for TURIS vis-a-vis HOLEP and green light. The green light was best in that case. And coming to the complication results, the capsular violation was much higher for TURIS. I don't know, this is their observation. Then the anemia necessitating blood transfusion, there are 4 patients required blood transfusion, 6.5%, which to me is very high, but since I don't know the details of the article, so this is what their observation is, that the TURIS requires more blood transfusion for a prostate of 80 grams, contrary to what we see here. And then the later on complications, the bladder neck contractions, the residual prostate adenoma, and the amount of the non-improvement in LUTS was much higher for TURIS vis-a-vis HOLEP. In their study also, the HOLEP was scored very high. And just to shorten it up, there were 60, 60, and 62 patients in each group. The longer operative time was for green light versus the HOLEP versus the TURIS. There was a higher rate of capsular violation for TURIS group vis-a-vis there was none in the HOLEP, which to me is maybe the experience matters. Slightly longer hospital and catheter times were reported following TURIS, which is 2 days versus around 3 days versus 1.5 days for half the time for the laser technology. Significant more drop in the post-operative hemoglobin and hematocrit values for the TURIS, understandably so. And the 3 years retreatment for recurrent bladder obstruction was significantly higher following TURIS vis-a-vis the HOLEP technique. This is what they observed. So what they have concluded is that perioperative outcomes of green light and HOLEP score very high over the TURIS for the treatment of large size prostates. The 3 techniques achieve good functional outcomes, and however the 3 years retreatment rate after TURIS and green light was inferior to HOLEP. So the HOLEP scores in both the papers, what they've shown is that HOLEP scores over the other technologies what we have been using. So I would surely like to have the comments of the seniors after that. Thank you so much for having me here. Thank you so much.
Thank you, Dr. Rahul. May I invite Dr. Amit Chakravarti for his comments, and may I invite Dr. Anup to please introduce Dr. Amit.
Thank you, Dr. Tanuj. So I will take the privilege to introduce Dr. Amit Chakravarti formally, although he doesn't need any introduction. He's a board-certified urologist, chairman of Poplar Bluff Urology in Missouri. He's been practicing adult and pediatric urology for the last 30 years. And he is the director of Center for Continence and Female Pelvic Health. He's a primary investigator at Longwood Research. His main areas of interest include minimally invasive therapy for BPH, male hypogonadisms, erectile dysfunction, female urology. He has several publications, and he has been proctors for many of these procedures internationally and nationally. And also he's an adjunct faculty for University of Alabama. So thank you very much, Dr. Amit Chakravarti, sir, for joining us today, and please give your comments.
Yeah, thank you so much. It's an excellent review, and I'm really enjoying being here. Thank you, Anup, for inviting me, and thank you, North Zone USI, for this honor. Here is my take on it. I have done all kinds of processing that I believe every urologist should have in their armamentarium. It's supposed to be an a la carte menu, not a buffet. You cannot do one size fits all in prostate, and you've got to be adaptive to the patient's needs and also the outcomes and what you are most comfortable with. Having said that, I mean, we can stretch ourselves to do HOLEP in smaller glands, but we all know, I don't know whether you have experienced that or not, but in my hands, we know that HOLEP, holmium laser, is not the best vaporization tool for prostate. We know green light laser is much better vaporized, especially the XPS, which is the 180 watts. Various reasons for that. Number one, it is hemostatic, because green light laser gets absorbed by oxyhemoglobin, and that's the reason it's the most hemostatic type of laser prostatectomy. I do those patients, whoever on Coumadin or warfarin, for example, or any of the anticoagulants, I don't stop them, and that's one advantage of that. Minimally invasive procedures we talked about. We used to do transuther needle ablation, radiofrequency, microwave therapy. Now they have gone a little bit out of this favor because we've got two new kids on the block, Resume, which is a water vapor therapy, and Urolift. They have their own roles, and we need to have them, offer them to people who actually need them, giving the caveat that we don't know after we have got a 4-year data, we don't have robust data beyond that. And having said that, we have got a large gland, and here is where we need to decide that should I do a TURP, even in saline. If we can do it, there's no, we don't talk about post-TURP syndrome, but at least we talk about it's a larger gland, and though time constraints are not that much as when we did TURP monopolar growing up, we could not do it for more than an hour a section. Nowadays, that thing is a little bit less because of saline. However, having said that, larger glands, we try to enucleate, and that's where HOLEP comes in. Here is my take. Here is my problem with HOLEP. I have done several HOLEPs, bigger glands. Morcellation is, especially if you don't have absolutely clear view, it is a dangerous technique, especially if you don't distend the bladder adequate enough, and you're morcellating the gland, which you have, it is something which is something to be considered about. So that is the reason I started one technique called green light enucleation of the prostate, or green light XPS enucleation. And I would take this opportunity to take a minute of your time to show my that technique for a second, so that this was presented at the at the World Congress of Urology in South Africa, and this was co-presented. Actually, I couldn't make it, so Anup actually presented this there. And this is I'm going to fast forward everything. So basically, what I do is that this is green light laser, and I'm going to fast forward it because I'll just keep it as absolutely short. So now I'm actually scalloping out the median lobe. So the median lobe is being scalloped out. Now remember, when you do morcellation, you have to buy that morcellating unit also as a separate cost of the unit. And in USA, disposables in India, maybe you can re-sterilize. But in the USA, there are a lot of disposables also, which comes into play. So we need to think about something where we can do an enucleation, yet not have the learning curve of morcellation and not have the cost of morcellation. So here is what I do. I scallop up the median lobe and have it hang just like a mushroom, if you notice. So this is just hanging with a little stalk. Make sure it hangs like a mushroom. It is not, if you let it go, then what I do is take the green light fiber out and put a 3 centimeter Segura basket into the scope and grasp it with the Segura basket and pull it out. Worst comes to worst, I have had to do a couple of small myectomies to take this thing out. So, so having shared that is the technique which I use. Now, what happens with this is that green light laser, to go up to 180, if you go up to 180 with a channel completely closed, it takes, there's a lot of bubbles, and you have to first go with 80, then 100, and open the channel wide enough so that you can go up to 180. All of us know that who has done green light. With this technique, you can immediately within 5 minutes get about 30 to 40 grams of tissue out and also open a channel that you can ramp it up to 180. So this gives the best of both worlds. This was presented at the WCE in South Africa. I think Anup can give you the link to that thing, and the details is there. So I would like to stop here and ask anybody's comments, other experts to comment on this. Thank you.
Yes, thank you, Dr. Amit. I think it's very innovative technology, especially you use the basket to remove a whole piece of enucleated segment down through the urethra. I think that I agree with you. Green laser is very good in hemostasis because of the mechanism absorbed by the hemoglobin. But one you know about the whole lab is that this end fire of the laser probe, but for the green laser is sci-fi probe. So I think that I've tried both. I think that the learning curve of green laser is a little bit longer as compared to whole lab because the sci-fi sometimes you need to pinpoint the bleeding vessel, so you need to have a good experience for the PVP first for the green light vaporization. Once you get adapted to this sci-fi probe, I do think that is much better than whole lab.
Anuj, if you can give me 30 seconds, can I make some comment?
Yes, sir, Dr. Amlesh, sir, please. And then Dr. Gupta.
The comment that I would like to make is about the morcellation, because morcellation is the dangerous part in whole lab. And to make morcellation safe, what we do is we connect water to both the inflow as well as the outflow. With that, what happens is that there is a good amount of inflow into the bladder, and that entire fluid gets sucked out by the suction which is present in the morcellator. Morcellator has a suction in it, and therefore your bladder wall is significantly safer if you connect a good amount of inflow using both the inflow as well as outflow channels. Thank you.
Thank you, sir. Dr. Gupta, sir, your comment, please.
Yeah, I like to make only, we are talking about TURIS and the bipolar TURP. So TURIS procedure is done with the Olympus, and the loop which is used with the Olympus is a thin loop. I have working with the Storz Autocon, and they have a thin loop and they have a thick loop, that is the 4 millimeter loop for the resection of the prostate. And my personal experience is that the cutting and coagulation is much better with the thick loop. And that is my practice. My students who have worked with me, they all know that. And I'm using this bipolar since last year 2000 actually, and I'm very much satisfied. Second comment I want to make about the blood loss with in tourists, it is more because of that region actually. And whenever I have used that Olympus system in my department, we have both. I have found more bleeding in that particular case. Those are surgeon is same, experience is same. Second comment I want to make about the technique of doing the TURP. I have a technique of we call it an anatomical resection of the prostate, where I do like going to the capsule first actually, taking away the, controlling the bleeding, and then resect the tissue very fast. And that I can resect any size of the gland with very comfort. So what I'm saying is that the person who is doing the surgery, all these outcomes can be different according to your technique, which instrument you are using and all that.
Thank you, sir. So moving on, if there are no comments, we'll move to the next session. May I invite Dr. Nitin Negi for his talk, please, on rhizome and echoablation. Dr. Nitin Negi, please.
Yeah.
Yeah, we can see your screen, but you need to select the presentation instead of the Zoom meeting. When you start, share. Yeah. Please go to slideshow mode and.
So is it visible?
No, again, we can see the Zoom. Yeah, now it is visible. Yeah.
Okay. Okay, good evening, everyone. So first of all, I would like to thank everyone for giving me this wonderful opportunity. As we all know that TURP is the gold standard in surgical management of BPH, and all newer minimal invasive surgical techniques are being compared to TURP in terms of safety and efficacy. So as to strike a balance between the efficacy and the side effects, especially the sexual side effects of TURP, constant endeavor is there to
bring up new technologies, and aquablation and Resume are two such novel technologies in the landscape of surgical management of BPH. So Resume is basically a thermal convective water vapor therapy wherein steam is being delivered to the prostatic tissue, which causes necrosis. It's a day care procedure done under local anesthesia. And the major advantage is that it has got very less sexual side effects. But the biggest drawback is that there is no tissue available to us for histopathology. Aquablation, on the other hand, is a non-thermal hydrodissection therapy wherein high-pressure water jet is being delivered by a robot under truss guidance, and this can be done under general or spinal anesthesia. And as Resume therapy, this too has very less sexual side effects, but here we do get the tissue for histopathology. So coming on to the first trial, this was by Rawborn and McQuarrie, and it was a prospective randomized control trial done to assess the 5-year functional urinary outcomes of Resume therapy. In this trial, 197 patients with more than 50 years of age with IPSS scores of more than 13, Qmax less than 15 mils per second, and prostate volumes ranging between 30 to 80 cc were randomized 2:1 to thermal therapy, that is Resume therapy, or the sham control, that is rigid cystoscopy. So coming to the results, compared to the control group, there was a statistically significant reduction in the IPSS in the active treatment arm. And the mean reduction in IPSS was around 10.4 points. Qmax also improved significantly with a mean increase of around 4.3 points. Also, there was a similar outcome when there was a crossover of control subjects to the Resume therapy arm. And we can see the retreatment rates. There was around 4.4% surgical retreatment rate at the end of 5 years, and around 11% patients had initiated BPH medications. So coming to the conclusions of this Resume 2 clinical trial, it offers rapid improvements in LUTS quality of life and flow rate that remain durable up to 5 years. It has its own advantages with a strong short-term safety profile and no reports of de novo sexual dysfunction. It appears to be a very fascinating procedure. It can be used for obstructing median lobes, and it has a short procedure time and is considered to be cost-effective, especially in Western countries. But there are a lot of disadvantages. We have very limited long-term data available regarding this therapy. Patients with urinary retention, history of recurrent UTI, large prostate size were excluded from this trial. Patients who had undergone prior surgery for prostate or prior radiotherapy for prostate were also excluded from this trial. So we really don't know how Resume is going to fare in this group of patients. Now coming to the open water trial, this was done with the objective to determine the safety and efficacy of aquablation therapy in a real-world commercial setting. It was a prospective multi-center single-arm international clinical trial where 178 men with prostate size of 20 to 150 cc underwent aquablation. The mean IPSS was around 22. The mean prostate size was around 60 cc. Around 60% of patients had a median lobe, and the mean Qmax was around 9.6 mils per second. The mean operating time of aquablation was around 24 minutes, and we can see the results. The results were very satisfactory. There was a marked reduction in IPSS. The mean decline was around 15 points at the end of 12 months of the study. Uroflow also improved significantly. But on the complication side, we can see that there was only 8% retrograde ejaculation. Only one patient had urinary incontinence, and there was a 2.7% transfusion rate, and there were no retreatments at the end of 1 year. So it was concluded that aquablation is a safe and effective therapy with symptom improvement scores and uroflow improvement comparable to other resective techniques with a significantly low rate of sexual dysfunction. Now coming to the water study in proper, this was a double-blinded randomized trial. It was a 2-year study done to compare the safety and efficacy outcomes after aquablation or TURP for the patients of BPH. In this study, 181 patients with BPH were randomly assigned 2:1 to either aquablation or TURP, and neither the patient nor the follow-up assessors knew what surgical treatment was being offered to the patient. Follow-up assessments were done in the form of IPSS, Uroflow, male sexual health questionnaire, and erectile function questionnaires. Now, comparing the aquablation and the TURP arms, there was a similar kind of demographic, and the mean prostate size was around 50 to 54 cc. The results were very encouraging. There was a significant reduction in IPSS in both the aquablation as well as the TURP arm. Uroflow rates also improved significantly, and there was hardly anything to choose between the two modality in terms of efficacy. But when we come to the complications part, we can see that the Clavian Dindo grade 1 complications, which included incontinence, ejaculatory dysfunction, and erectile dysfunction, were way less in the aquablation arm compared to the TURP arm, but the remaining complications were quite equivalent. And the surgical retreatment rate in the aquablation arm was around 4.3% at the end of 2 years, while it was only 1.5% in the TURP group. So the conclusion was that aquablation offers similar durable outcomes at 2 years compared to TURP, and it gives a significantly lower rate of sexual dysfunction. So impressed with the results of aquablation therapy in small and medium-sized glands. Water 2 trial was conducted on bigger glands, and this was also a 2-year study which was done to assess the safety and efficacy outcomes of the aquablation procedure for patients with prostate size of 80 to 150 cc. In this study, 101 men with moderate to severe LUTS underwent aquablation, and the mean IPSS was around 23. The mean prostate size was around 107 cc. Median lobe was present in around 80% of patients. The mean Qmax was around 8.7 mils per second. And we can see that the mean aquablation resection time was around just around 8 to 10 minutes. So the results were very gratifying. Aquablation therapy could easily meet both the safety as well as efficacy endpoints, and the mean IPSS reduced from 23 to 5.8. The mean uroflow improved from 8.7 to 18.2 mils per second. Complications were quite acceptable. There was a 18% complications in the grade 1 Clavian Dindo group, and it was concluded that the efficacy outcomes of aquablation remained durable at 2 years of follow-up. Operating room time efficiency remained favorable even with these largest prostates. Hemostasis could be successfully achieved without cautery in all the cases, and the combination of robot and truss significantly reduces the tissue removal time independent of the operator skills, prostate anatomy, and its size. And there was a very low average annual retreatment rate of around 1.5% per year. So aquablation is basically not a panacea for BPH. It can be a surgical alternative, and it has its own merits in the form of low operating times, shorter hospital stay, lesser sexual side effects, a smaller abbreviated learning curve, and acceptable complication and transfusion rates. But there are limitations of these studies. First of all, there was no control group for this Water 2 study. These are very short duration follow-up studies. High quality studies are lacking, and cost benefit analysis also needs to be taken into consideration. So at present, currently, there is very weak recommendation for aquablation therapy, and healthy LUTS patients with mid-sized prostate glands of around 30 to 80 cc who are interested in preserving their sexual functions might benefit the most with this therapy. Thank you.
Thank you, Dr. Nitin. May I invite Dr. Lokalun for the expert comments? Just a brief introduction. Can you stop sharing your screen, Dr. Nitin? In the meantime, I would like to give a short, brief introduction of Dr. Lo Kalun. Dr. Lo is a clinical assistant professor at Chinese University of Hong Kong. His areas of interest are bipolar, rhizome, transperineal biopsy, and BTESD. And he is director of BPH registry in Hong Kong, and he is the chairman of Asian Prostate Federation. Thank you, Dr. Lo Kalun, for joining us. Please, your expert comments, please.
Thank you, Dr. Tenepor, for invitation, and also all the organizers committee. I think this one is very good platform to share our experience together, and also with a wide spectrum of the specialty, including the endourology, PGNL, and RS. I enjoy a lot of this discussion tonight. And also, I agree with Dr. Ahmed that not only the method of the education or novel treatment can apply to all patients. I would think that it depends on the patient's condition, prostate size. I would say that if the prostate is very big, like let's say it's more than 80 grams or more, enucleation is a good treatment choice. But if the patient is young age, want to preserve the sexual condition, the local treatment, including rhizome, is very good. For those patients is not that fit for general anesthesia or spinal anesthesia, Mimocap prostate stent is one of the good options that you can choose from. For me, I've tried the rhizome, and also our center also have the aquablation urolift. For the rhizome part, I would say that the beauty of the rhizome is the airway procedure. In my case, I have tried one case, obstructive uropathy, the ASA-free patients, high risk for general anesthesia. The patient finally opt for the rhizome. After the Foley catheter, the patient can successfully treat TWC with normal renal function afterwards. So this is a good case that demonstrates the resume can have the place for those patients who have high risk for general anesthesia. But for the big prostate, let's say more than 80, I would say that the resume is very difficult because it takes longer time to effect. Usually it takes 2 weeks or more. So the patient need to have the catheter. This is one of the drawbacks of the resume. At the same time, the patient have some dysuria, but most of them is self-limiting and have been treated by some medication is good enough. I think that the resume is a very fast procedure. It usually take 5 minutes, and you can done under the local anesthesia, and the patient can be discharged on the same day. So in the era of the COVID-19 pandemic, I think the resume is very good so that the patient cannot stay in the hospital for a long time. However, the cost is also need to be concerned because each case take around 10,000 Hong Kong dollar per case at least. And at the same time, as compared to TRLP, the cost is much attractive for the conventional bipolar TRLP. At the same time, if the patient have anticoagulant, usually I need to stop the anticoagulant before the resume case. So I think one of the drawback is that the patient maybe have median loop, but the resume claim that there is very good at median loop for the resume case. So I don't have any experience for the large median loop, so maybe in the future I can try it. For the aquablation, I think in the EAU guidelines already comment that is kind of an investigational procedure because one of the drawbacks of the aquablation is the bleeding. We have tried a few cases in the past and find that the bleeding is a little bit difficult because you know that the aquablation there's no effect on hemostasis. After the procedure, if you find there's bleeding, sometimes you need to insert your resectoscope to have hemostasis again. However, after the aquablation, the surface is very irregular. Sometimes it's kind of difficult to use the resectoscope to have good hemostasis. And you need to have reset a bit so that you can find the bleeding source. So it takes longer time. So even though your so-called resection time of the aquablation is short, but however, the total operation time together with the hemostasis is more or less similar as conventional TRP. In our case, we also come a case that there's continuous bleeding after the aquablation despite the Foley traction, also some hemostasis after resection. So we do need to go in for re-operation again for the hemostasis. So another cause is probably is we miss some bleeding despite the Foley traction, then the bleeding is still ongoing. The blood transfusion rate, if for the big prostate more than 80 grams, according to EAU guideline, the transfusion rate is also very high. So in EAU guideline also comment that if you discuss with patient that you need to warn the patient that the bleeding problem is one of the consideration of the aquablation. But other than that, I do find that the aquablation is very innovative procedure because they have a very good sexual function preservation and the patient can be discharged at very short term. So this is my comment on the resume and aquablation. Any comment from the experts or other organizing committees?
Dr. Low, if there are no other comments, we'll move on to the next session. Thank you so much for the experts and present. Sir, yeah, Dr. Amit, sir, sorry. Yeah, please go ahead, sir. Yes.
Just a very quick comment. I'll not be long. Resume. Again, like I said, the new kid on the block. The good news, good things are obviously because it also has very low rate of retrograde ejaculation. Aquablation, I have not tried because it takes a lot of more equipment and everything else, and hospitals have to be in line with that. Resumes can be done in the office. Literally takes 9 seconds. Each treatment is 9 seconds. And usually for a gram between, you can only do it between 30 and 80 grams. That's what it is approved for. Between 30 and 80 grams, you can do median lobes. But the advantage of this is that literally it's done in 2 minutes. And though Resume, according to their educational package insert, they want you to leave a catheter in. I send my patients, a lot of patients who are not in, do not have a high post-viral residual, I send them home with self-cath just in case, because the chances of them needing self-cath is less than 5%. So it's an extension from what I used to do as a tuna transurethral needle ablation that used radio frequency. Steam, the advantage is that it actually permeates through the gland a little bit better than radio frequency. I've had good results with Resume, except for, I agree with Dr. Lowe, I've had a few patients who complained of dysuria, and that has been my main major concern. Otherwise, it's a very quick procedure. I can easily do 10, 12 procedures in one day, and it doesn't stress my staff also. Thank you so much.
Thank you so much, sir, for your comments. So thank you so much, experts and presenters of the first session. We move on to the second session, which is about techniques and outcomes. So I would like to invite the experts, Dr. Anil Vashne sir and Dr. Rajesh Taneja sir, for this session. And we will start with the first talk from Dr. Praveen Pandey.
So am I audible, Dr. Tanuj?
Yes. Please share your screen.
So I'll just share my screen. Yeah. So is my screen visible now?
Yes.
Absolutely. Okay, so I'll just move it. Good evening, everyone, and thank you, NZUSI, for giving me this opportunity to be here and present some of the abstracts for you. And I'm Dr. Praveen Pandey from Lucknow, and I am practicing consultant at Sahara Super Specialty Hospital. So this is the first abstract I'll be talking about. It is about the novel OLEP technique, that is the omega sign technique that is claimed to improve continence outcomes of surgery. This article comes from Tank et al. He's a very strong proponent of this omega sign technique, and he hails from Turkey, Gazi University of Medicine. So this study, what they did, they around 400 patients, they enrolled 400 patients in the timeline from May 2016 to 2019, and out of 400 patients, 200 patients were put in group 1, where the HOLEP was performed by the standard Gillings technique. What is Gillings technique? It is a standard 3-lobe technique. You all are familiar with it. Most of us do by this technique. And the next 200 patients were placed in group 2, where the omega sign technique was used for HOLEP. So they analyzed continence status and post-maturation symptoms in both the groups after the procedure. And according to the authors, the omega sign technique is based on the topographic anatomy of the external sphincter. I've just provided a short YouTube link for the video if people are more interested in the exact technique. But frankly speaking, what happens in the omega sign technique, it is almost similar like the standard 3-lobe technique. The only difference is that a small amount of mucosal strip, that is from 2 to 10 o'clock position, is just kept intact. And first the median lobe followed by the lateral lobes are enucleated. So this is the view from the urethra, where you can see the lobes have been enucleated and the strip at the mucosa is intact at the 2 to 10 o'clock position. This is the view from the urethra side. And if we have a antegrade view from the bladder side, and this is the view, the whole of the tissue has been enucleated and the strip of mucosa that is left intact. So this is about the omega sign technique. So these are the results. They analyze the stress urinary incontinence, the urge urinary incontinence, and post-maturation symptoms on the day of catheter removal in both the groups at 1 month, then after at 3 months, and after 6 months of the procedure. So what they found at the day of catheter removal, there was statistically significant improvement in the omega sign group, where the stress urinary incontinence was less, the urge urinary incontinence was less, and the post-maturation symptoms were less. So these are the observations on the day of catheter removal. Again, after 1 month after catheter removal, again similar findings were noted. The statistically significant results were noted, and stress urinary incontinence, urge urinary incontinence, and post-maturation symptoms were very, very less compared to the standard Gillings technique. However, after 3 months and 6 months, the results were not as promising as they were initially. So this is what was noted. So the authors concluded that omega sign technique provides better continence results comparable to the functional with comparable functional outcomes. That is, the results, the other functional outcomes are equivalent as compared to the other technique, but they provide with the better continence results. At the same time, they have equal minimal complications compared to the standard HOLEP technique. What are the advantages that they notice? They notice that the omega sign technique decreases stress urinary incontinence rate, and they see that this is this technique seems to have a shorter learning curve, and it will be standardized soon. So this was the first abstract that I've reviewed. Now this is the second abstract. I'm coming to the second topic, that is the anterior posterior urethral mucosa preservation technique in one lobe enucleation HOLEP, which has shown to be which has a potential to reduce post-surgical incontinence. So the authors are from Japan, Faculty of Medicine, University of Miyazaki Hospital, Fuzusaki, Italy. What they did, they enrolled two groups, patients in two groups. One group was having 153 patients, where one lobe HOLEP was was done. That is the N block HOLEP was done with anterior posterior urethral mucosa preservation technique. And here the patients were enrolled from 2018 to 2019. The other group was the patients having 161 patients. Here one lobe HOLEP was done without APUMP. That is the N block HOLEP was done as most of us know it. Here the patients are enrolled from 2017 to 2018. They compared age, calculated prostate volume, weight of enucleated adenoma, and time of enucleation. Maximum flow rates were assessed at 3 months. Urinary incontinence rate at catheter removal and at 1 month were noted and analyzed. So this is a non-APUMP technique. What non-APUMP technique? That is a standard N block enucleation of HOLEP. Out here, simply enucleation is started first at the median area at the 6 o'clock position, then an longitudinal incision is given at the 12 o'clock position, and then the N block enucleation is done along with the lateral lobes first, and then from the base, that is the median lobe, and then the whole of the prostatic tissue is N block enucleated into the bladder. So this is the standard technique, N block technique. Now, what is the modification in the APUMP technique? Out here, the 12 o'clock mucosal strip is kept intact. So what is done here? An incision is made longitudinally around from 1 to 11 o'clock position, from where the mucosal strip is kept intact, and the rest of the enucleation N block is done as before. So we are just preserving 12 o'clock or 1 to 11 o'clock mucosal strip, which is shown at the end, and the rest of the enucleation of the prostate is done as in the previous technique. So these are the results. The surgical outcomes were compared in both the groups, and it was seen that the enucleation time was significantly less in the APUMP group. And again, they also noticed that the incontinence rate after the surgery was again significantly lesser in the APUMP group. And again, the incontinence rate at the 1 month after the surgery was still less in the APUMP group. So rest of the parameters, that is enucleated weight and the median Qmax change pre-op and post-op, was almost similar in both the groups.
You have 1 minute to go, Dr. Praveen.
Yeah. So and again, they also noticed that the APUMP technique made a significant impact in predicting the urinary incontinence at 1 month. So they concluded that it is this technique is performed with a shorter time, equal improvement in urinary flow is noticed, and post-surgical urinary incontinence rate was significantly lower, and it was associated with urinary incontinence, less of the urinary incontinence after the surgery. So now this is the last abstract. I'll go fast. This is from Cambridge University in UK. Here, the abstract tends to address the matter whether does the size of the prostate matters. Holmium enucleation of the prostate with a gland volume over 200 cc. The techniques, the outcomes were analyzed. All the patients were having prostates more than 150 gram. There were 3 subgroups depending upon the size of the prostate, and the parameters analyzed were intraoperative, postoperative, and functional outcomes. Now this is the result. The first group was of patients from 200 to 250 cc, next was 250 to 300 cc, and then more than 300 cc. Intraoperatively, enucleation time was obviously slightly higher on with the larger size of the prostate, but the cystotomy, that is for the removal of the lobes, was more in the prostates which where the size was more than 300 grams. Post-operatively, the duration of stay was almost same. The transfusion rates were significantly higher in the prostates that were more than 250 cc. And the main pre-op and post-op IPSS, yes, there was improvement. Qmax, there was improvement, and the residual volume, yes, there was significant improvement. So the conclusions is that the size is not a barrier for HOLEP more than 200 cc. A concomitant cystotomy is more common in men with prostates more than 300 cc. And for prostate volume more 200 to 200 cc and more than 300 cc, they propose a term mega and ultra HOLEP respectively. Thank you for your attention.
Thank you, Dr. Praveen. May I invite Dr. Anil Varshney, sir, for his expert comments, please?
Good evening, friends. And it's I must thank Tanuj and North Zone USI for giving me this opportunity. And here the papers which have been presented are first two are stress urinary incontinence, and that is a very important thing because the adoption of HOLEP was delayed quite a lot just because of the fear of stress incontinence. And the point which has been highlighted is preservation of anterior urethral mucosa. And the first paper was Omega technique. Both of them are talking more or less the same things. And this is, if we see that all these comparisons, the incontinence is there. Even in Gilling's technique later on, and even after this preservation of anterior urethral mucosa, there is a incontinence, though the incidence is less. So the point which must be understood is that there are other factors also besides the surgical technique. However, the other factors could be the age of the patient, the diabetics, or it could be patients who are having very large prostates, or if the time taken during the surgery is long, and even the learning curve. All the operators in the initial learning curve, they have more incidence of incontinence compared to late. But coming to the Omega technique, it is very important to understand that defining the external sphincter, the topographic anatomy as has been highlighted in this paper, it is the topographic anatomy which is very, very important. And you must, whosoever is learning, must cite the external sphincter in the beginning itself. And one must go at least 5 millimeter to 10 millimeters proximal to the external sphincter to mark this distal limit. So if you mark this distal limit, which was presented by us 10 years earlier, that if you mark this distal limit, the incontinence rate goes down. But my objection to this technique is that the size of the prostate, if you look at the second paper, the size of the prostate is around 45 to 50 grams. So for smaller prostates, the anterior strip is very thin. And in small prostates, we always say that you must preserve this anterior strip from say 11 to 1 o'clock. That preserves not only continence, but also is a future prevention for bladder neck contractures. So therefore, this is important for small glands. However, when you have large glands, then what happens is that in large glands, it's very difficult to predict the thickness of the tissue anteriorly. So the Gilling's technique tells you making in total incision at 12 o'clock. And if the operators who have done this HOLEP at the 12 o'clock, many a times the tissue it could be 1 to 1.5 centimeters or even more at only anteriorly. So the point which I want to highlight is that there were few patients who were having this, rather they were doctors. And these doctors, when they underwent this technique of anterior mucosal preservation, because most of the operators, they find that one has to preserve this anterior mucosa. And one patient had urosepsis. He had to be put on inotropes. Ultimately, we did SPC because his counts had to be stabilized, and we had to remove this anterior tissue which was infected. Similarly, we had another doctor which had recurrent UTI following leaving this anterior mucosal strips, and every month he will get this meropenem intravenous, and then ultimately this anterior tissue had to be resected. So what I want to highlight is that it has to be an individualized assessment. Learning curve plays a big role, and we must preserve this anterior strip. So we must preserve this anterior strip, and that is in small glands. However, it is an individual decision in large glands. In large glands, one has to really tailor, because you cannot leave whole anterior tissue. So this is one comment. The second paper, that is the large prostates. And in large prostates, it's a very good paper, and we really appreciate that very high quality though it is a retrospective analysis, but this is a prospectively collected data, and the data gives us the up to 300 plus grams prostates which have been enucleated. The point which I would like to say is that in large prostates, the enucleation time, you must have noticed, it is only 70 minutes. If you have 250 gram prostate and you can enucleate, so that is the beauty of HOLEP. Most of the operators, they feel scared that they have to do large prostates and it will take long time. But enucleation is less. But the question of morcellation, which has been highlighted earlier, that morcellation is at times troublesome. And therefore, as an expert, I must say that one can safely stage. What I have seen in this paper is that they have tried to finish the procedure in the same sitting. This could be their technical compulsion, but they have done a cystotomy to remove in 6 patients the large lobes. Very, very rarely you will need a cystotomy. Rather, you stage the procedure. In India, it is very easy. After 48 hours, if you go for doing the morcellation, the whole, even if it is 300 gram plus tissue, it can be safely morcellated or enucleated. Only point is that in very large prostates, many a times you are not able to reach to the bladder neck while enucleating. And 2 cases I just did this thing, suprapubic enucleation, anterior enucleation combined with retrograde enucleation. So that could complete the thing, and suprapubically you can morcellate. So another point which must be highlighted is that suprapubic morcellation is a feasibility and it is easy, and that reduces your total urethral time also. So therefore, all the 3 papers are good papers. They are important for the establishment of HOLEP, improvement of this minimizing stress incontinence, and giving confidence to all the learners about the technique. Thank you.
Thank you, sir. Okay. Taneja sir, if there's any quick comment from you.
Yeah, thank you, Tanuj, and thank you very much for giving me this opportunity for the expert comment. I fully agree with Dr. Varshney that you cannot leave behind large chunks of devascularized prostate. And so a blanket statement that you can do an omega or leave an anterior urethral mucosa, because mucosa has prostatic parenchyma behind it. And if you leave behind a devascularized prostatic parenchyma, because unfortunately, the prostates that we see are not designed by machines. They are naturally designed, and sometimes you will see a large anterior lobe projecting into the bladder, and that can be a real challenge. And if you try to leave it behind, you are not going to be successful. That's all I want to add.
Thank you so much, sir. So we'll move on to the next talk. May I invite Dr. Shailesh Sahai for the next talk, please. Dr. Shailesh?
Yeah. Hi, am I audible?
Yes, sir, you're audible.
Are my slides visible?
Yes, we can see.
Okay. So very good evening to everybody. So I'm going to discuss 4 papers on BPH, and I'm allotted 8-minute time. Would like to be in time because I know that we are running late. This first paper, it's discussing recovery from transient urinary incontinence post-HOLEP. This is a prospective trial and known as EXPO study. It's a paper from Milan, Italy. And as we know that transient urinary incontinence is a relatively common complaint after HOLEP. So this study investigated the probability and predictors of urinary continence recovery over time in a cohort of patients submitted to HOLEP at a single academic center. So this trial, being a prospective observational study, they collected data of patients whose HOLEP were performed by a single high experienced surgeon with more than 1,000 procedures completed at a single academic center. Before surgery, IPSS scoring was recorded, and after surgery, at 1 week, 1 month, 3 months, 6 months, and 12-month interval, their urinary continence was assessed and scoring was done. Post-operative urinary continence was defined as no pad or no safety pad, and Kaplan-Meier analysis were used to estimate the probability of urinary continence recovery over time. Landmark analysis were applied to compare the probability of urinary continence recovery among different times elapsed from HOLEP. So when you see the result, then data from 112 fully continent patients, and it was the median age was 68 years, and median IPSS score was 18, and prostate volume was 92, and median post-op follow-up was 90 days. So nearly half of the patient, 54% of the patient were continent at the time of catheter removal. And when we see in the interval, then at 6 months, almost 92% patients were having full continence. It was almost 6 months. We can say that most of the patient had recovered. However, the recovery proceeded till 1 year interval. So a significant lower probability of urinary continence recovery was seen as the time elapsed from the surgery. So most of the patients recovered in the early phase. When we compare the other parameters like age, baseline PSA, IPSS, they were not predictive of urinary continence recovery over time. So this is the recovery period that's shown. And in 12 months, we can see the IPSS scoring, how they recovered. Peak flow rate also improved. And this continence status, we can see at 6 months, 92% patient recovered. And at 12 months, 95%. So to conclude, the post-operative urinary continence was achieved within 6 months post-HOLEP in most of the patient. And patient experienced urinary incontinence at catheter removal were unlikely to improve soon. And initially they were managed, but proper counseling is required for such patient that those who are incontinent, we have to wait at least for 6 months before proceeding for any other treatment. The second paper, it's impact on sexual function of endoscopic enucleation versus TURP for lower tract symptoms due to BPH. So this study is from China, and it was done to find out if there is any difference on male sexual function status after TURP versus endoscopic enucleation procedure. So the meta-analysis was done to investigate the impact on erectile function and ejaculation of EEP and TURP, and literature search was conducted on Medline and Cochrane Library. So outcome data were pooled and analyzed with Review Manager 5.3 system, and IIFF 5 score and retrograde ejaculation rates from short to long-term follow-up was done. So there were 10 articles selected with 1,435 patients in total, and EEP group showed that higher IIFF scores than TURP group, with mean difference being 1.0 at 48 months and 1.08 at 60 months respectively. But in subgroup analysis, the HOLEP showed significantly better IIFF score than TURP group at 48 months and 72 months. There were no significant difference in terms of retrograde ejaculation rate in EEP and TURP. So what they conclude that compared with TURP, endoscopic enucleation procedures may produce a more durable benefit for post-operative preservation of erectile function at long-term stage. The third paper, that is showing influence of holmium laser enucleation of the prostate on erectile function. It's a study reported from France, and the aim was to investigate the evolution of erectile function at 3 and 12 months after HOLEP. A multicentric retrospective study was performed, including 235 patients, and those who underwent HOLEP between January 2016 and June 2017. The evaluation of EF was carried out with the standard IF5 scoring before surgery, at 3 months, and at 12 months after surgery, and a change of more than 5 points in either direction in the scoring was, with as compared to the baseline, was considered as significant improvement or impairment of erectile function. So coming to result, there were no significant difference was found between median pre-operative IIF scoring and at 3 and 12 months. At 3 months of surgery, around 10% of the patient reported an improvement, whereas 15% of the patient reported an impairment. So at 12 months after surgery, 13% of the patient reported an improvement, whereas 16% had impairment. So it was not statistically significant, but the reduction in IIFF score was statistically significant in those patients who had normal preoperative erectile function. Like those patients who had IIF scoring more than 22 before operation, they were the one, and for 15% of the patient in such a subgroup reported there is a decrease of more than 5 points of IIF scoring. Age and high ASA score are also significantly associated with impairment of erectile function 12 months after surgery. So to conclude in this study, the median IFF score was not impaired at 3 and 12 months after treatment, but 14.9% of those patients who did not have preoperative ED were reported to have impairment. And the same finding has been reported in 2015 in Journal of Endourology by Jose Placer, and they also concluded that those patients without preoperative erectile dysfunction displayed a relatively small but still statistically significant negative impact on erection after HoLEP. So the last paper is do postoperative benefits continue after 10 years post-HoLEP or not? So this study was done to, this is from Italy, and it was done to investigate whether post-HoLEP benefit in terms of symptom relief were present at 10-year follow-up. So clinical and perioperative data from 125 patients submitted to who was having this HoLEP from 2007 to 2010, and with the same surgical technique in the same center by an experienced surgeon, they were analyzed. All patients reported a significant relief of symptom within the first 6 months after surgery, and they were asked to complete IPSS scoring at 10 years follow-up in 2019. Eurofilament parameters are also recorded and logistic regression analysis tested the risk of being symptomatic at long-term follow-up. So when you see the result, then at surgery, the median age was 67 years, PSA was 3.6, prostate volume was roughly 82, peak flow rate was 9, and PVR was 85. At 125 months follow-up, median follow-up, the peak flow rate was 16, PSA was 0.6, IPSS was 5. So overall, we see 25% of the patient was symptomatic at long-term assessment, and 5.7% of the patient reported urinary incontinence, that is more than 1 pad per day, while 4.7% underwent resurgery over the follow-up period due to bladder neck contracture. So if I see here, normally what we remember that 10% of the patient at 10 years may have recurrent BPH and need surgery. In this study, we see this is around 4.7%. Maybe this is due to advancement of the technique. And at multivariate logistic regression analysis, we see that older patient had a higher chances of this recurrence, as well as those patients who never recovered fully, their continence was not achieved. They were at higher risk of having a symptomatic BPH in long-term follow-up. So at 60 years old, if you see the data, then 60 years old men, they have 3% chances of having a recurrence at 10 years and needed surgery. While those patients who are around 75 years of age, they have 34% chances of requiring a redo surgery at 10 years follow-up. So the benefit of HoLEP in terms of symptom relief are still present after 10 years from surgery in most patients. However, we should be aware that older patients are at higher risk of symptom recurrence and persistence at long-term follow-up. Thank you.
Thank you, Dr. Shailesh. I request Dr. Rajesh Taneja sir for his expert comments.
Yeah, thank you very much, Shailesh, for this wonderful talk. Now I will address all the 4 papers point-wise. The first is that about the continence after HoLEP. Now, you will agree that this paper has come up from Italy, and in 2020. We have in India an experience of 2 decades of HoLEP. So the experience that the Indian surgeons have in HoLEP is unmatchable from this paper. I would offer this, and I'm sure others who have been doing this procedure for last 2 decades would understand that if we give a result of 54% incontinence at catheter removal, perhaps we would need to leave our subject and go somewhere else, do something else. So certainly this doesn't reflect the truth that is there. So let us not go back with the idea that HoLEP can cause this. It is HoLEP in the hands of the beginning. It is the HoLEP in the hands of the early learning curve, wherever, whoever is doing. I think we need to take it with a pinch of salt. I give full credit to the authors for being forthright and honest in reporting their reports. But I think we have to be very careful, and I'm sure all of us who are sitting here and have been doing HoLEP for so many years would agree that this is rather a large percentage as compared to what we find in India. And of course, as the learning curve improves, as the experience improves, the incontinence rate certainly drops. Now, coming to the other papers regarding the sexual dysfunction and HoLEP. So we also had from Apollo Hospital, our group, we published a paper. In fact, it was a thesis of one of the postgraduates to compare the sexual dysfunction between HoLEP and TURP. And of course, the difference between what is published in the literature is And in our paper was that our paper had a shorter duration of follow-up because it was only a thesis, so 6 months follow-up. And we found that there was no statistically big difference between TURP and HOLUP as compared to the erectile function. However, if we dissected the paper further, we found that patients had they had reduced overall function, sexual function after they had the same amount of reduction in overall sexual dysfunction. But when you looked at the sexual desire, it was much more in patients who underwent HOLUP. And as far as the orgasmic satisfaction, for some reason, was much better with patients of HOLUP as compared to TURP. Another thing in our paper was that we had segmented our population into age-wise data, and patients who were younger than 55 years of age, they had a very good response as compared to TURP. The patients who underwent HOLUP had a very good response, and they did not suffer from any de novo sexual dysfunction as compared to TURP. So we have a different data, but of course our data was only 6 months. But I agree that there is a sexual dysfunction which needs to be addressed, and it is largely unpredictable, and especially when you should never be able to promise. You cannot promise that, okay, I will do a procedure and your sexual dysfunction will not set in. Now there is another paper which talks about 14.9% of de novo.
Rajesh, I'd like to interrupt you. When you say sexual dysfunction, please clarify, it's a retrograde ejaculation you are talking, or
No, sir.
erectile dysfunction you are talking? Please clarify that.
Yeah, so I'm talking about the overall sexual dysfunction, which does include, see, the retrograde ejaculation is likely to happen in a majority of patients. In fact, it is very difficult to prevent retrograde ejaculation when you're doing any prostatic surgery, because you're meddling with the internal sphincter, you're meddling with the paracollicular muscles, which are responsible for ejaculation. But yes, I'm talking about the erections, the ejaculatory satisfaction, whether it goes in or out. It is the orgasmic satisfaction we are talking about. So all those things have to be combined in, and we subtract the retrograde ejaculation part. Erectile function, that is, if it is a de novo erectile function, which is 14.9%, I think in this paper it is a little higher, but yes, it may vary from operator to operator, but yes, it is a definite thing, and you should not promise that if I do a HOLUP, you will not have an erectile dysfunction. And regarding long-term efficacy of HOLUP, yes, it is very well established. I'm a little surprised because I cannot explain why elderly men who are above 80 years of age should have a poorer outcome, and maybe 1/3 of them, 1/3 is a big percentage. 1/3 of elderly men who undergo HOLUP require a retreatment surgery. I think this is not a true representation of what we have in India, and I'm sure my colleagues here in this group would back me up with their thoughts. Thank you, Tanuj. This is all I need to say. If Dr. Anil wants to say anything.
Yes,
hello. Yes, I think very interesting comments, Rajesh. There are 2-3 things which I would like to say. And one is the learning regarding the sexual function. I fully agree that we cannot commit that patient will not have sexual dysfunction. But at the same time, we have to be cognizant of the fact that what can cause sexual dysfunction. So the first thing is the preservation of ejaculation. Younger patients, we can preserve, and we have preserved in a lot of younger patients by seeing the ejaculatory ducts and avoiding them. And then can we go around a centimeter proximal, safely safeguard ejaculation function. The other thing which I would like to say is that one should not spend much energy onto the capsule. So your target is adenomectomy, and your target is not to put your energy onto the capsule. This single step, because I earlier in my series used to have this erectile dysfunction, and patients used to come and put their head down, sir, ye to khatam hi ho gaya sab. But then we started working on it, that why they are having this kind of a issue. And then lately, today, we are preserving the sperms in younger patients who don't have kids. But still, I have patients who have had pregnancies following HoLEP. So this is just to highlight that it is a technical expertise which can preserve their sexual this ejaculation part. The other thing which is very important and has been put in the last paper is the age or the timing of surgery. I think a very big message goes to the public that they should time the surgery, and this urologist also should time the surgery at the right time. The point which is I want to make is that if you keep delaying the surgery, if at 80 years of age, it is the underactivity part sets in. These patients don't have only BPH, they have bladder issues also. And therefore, the outcomes of surgery at 60 are different than the outcomes of surgery at 80. You are mixing up the potentials of bladder neck contractures, strictures, which are likely to be more at 80 years of age. So this has been clubbed together. I think we will have to dissect all the complications which are happening at 80 years of age. And they definitely are more than a 50 year of age or 60 year of age. This is just to conclude. Thank you.
Dr. Vashne, the only thing was, sorry, Tanuj, the only thing was that they talked about reoperation rate, requiring reoperation at 34%, which I would objection to. I fully concur.
Yeah, I agree with you. That is very high.
And many of our patients have had pregnancies after this. Thank you, Tanuj. Thank you, Anup. And thank you, everybody in North Zone. Thank you.
Thanks a lot for this opportunity, Tanuj. Thank you.
Thank you. Thank you so much to the experts and presenters of the second session. With this, I hand over the baton to Dr. Dilip for the next session. Sorry for exceeding the time by about 9 minutes. Dr. Dilip, please.
Thank you, Tanuj. We had a nice long session on the prostate, and it was very nice. Actually, it was much better to hear the experts speaking on the papers, because we need to know from them what exactly needs to be in papers. Can have variety of presentations and all the things, but experts are giving us the correct view. Anyways, moving on, without wasting much time, I would begin our session on other part of endourology, that is PCNL. I would like to invite our experts who are stalwarts in PCNL surgery, MS Agarwal sir, SK Pal sir, and Rajiv Sood sir, all are here as experts for this session. And without wasting much time, I would like to go on to Aditya Sharma, who will be presenting the initial first 3 abstracts. And Aditya is also a big name now. So Aditya, on to you. Aditya, we can't hear you. Unmute yourself.
Thanks, Dilip. All credit goes to you for giving me these nice papers. And I would like to start with the very first paper, because I've got just 8 minutes. So this first paper comes from Netherlands. It is about intraoperative cone beam computed tomography for detecting residual stones in percutaneous nephrostomy. So I'll just give the gist of it. We have all faced trouble of not being able to achieve complete stone clearance post-operatively, while on table, when we saw on fluoroscopy, we presumed that it was absolutely clear. And this is the dilemma even more increasing, because availability of CT scan, and the most patients they do post-operatively and they come back and showing Dr. 3 mm, 4 mm fragment is remaining there, or maybe sometimes bigger ones also. And so this paper actually addresses that problem. So cone beam CT, CBCT, it allows intraoperative cross-sectional 3-dimensional imaging for the urinary tract. So the idea is to intraoperatively just image the urinary tract once doing the procedure. So I'll just take a small clip of the video. So let's just go to the best part, I guess. So like you're doing PCNL, so this is the equipment which is being used. It's a very fancy looking machine. Once you see it in motion, you see this rotates the cone beam CT. It's actually a OT setup, entire OT setup. It is installed in OT and it rotates to 70 degrees. And the idea is to, once surgeon feels that, okay, he's not able to locate a fragment or he thinks he has cleared it. So it just takes 8 minutes to image the patient and tell the surgeon in 3 dimensions where a possible residual fragment might be, and the surgeon can of course go back and clear that. So this is the idea of this paper, and of course, as they mentioned, they have used this procedure in 19 cases. In 50% of the cases, they could extract the fragment. So in all the cases, the extraction wasn't possible, but at least the surgeon was wiser, going able to go back and tell the patient that, okay, there are some residual fragments immediately after the surgery and I may have to come back. And yes, 16% additional stone-free rate was achieved at the cost of 8 minutes of operative time, and we don't know the cost of the entire setup though. To conclude, of course, it helps in CBCT helps in detecting residual stones intraoperatively, and of course, the stone-free rates can be improved. So the few points which I think are important, because it is a right step in the direction of future and automation. We can sometime later we can imagine a robotic probe doing puncture itself while the patient is imaged by a CT, and maybe not suitable Indian perspective for long time due to cost issues and real life practicality, and parallel application in other surgeries like say partial nephrectomy. You do a contrast CT. I don't know. Maybe it's possible. So that was the first paper, and I'll go to next paper, which is from Bologna, and this is about 3D reconstruction and a physical renal model to improve percutaneous puncture during PNL. So this paper basically addresses the training. Like with earlier HOLEP session, we heard lot of misadventures happen while the surgeon is new and or the trainees operate on the patient. So in this way, what they have done, they do a 3D image reconstruction. So a contrast enhanced HD CT is done. 3D virtual reconstruction is done, which includes stone, parenchyma, urinary system PCS, and ribs. So all the bony and the soft landmarks are taken, and further, what they have done, the laboratory of bioengineering from Bologna, they made a 3D model out of it, and of course that 3D model was given to the surgeons beforehand, so that they can plan their punctures, they can visualize how and what. So this is like virtual reconstruction is done, and once it is done, they could 3D print the entire stone and model with parenchyma and the entire PCS. And of course, it is a very good teaching tool. Firsthand, one can show where the stone, how they want to proceed, and where they would want to have their puncture. And and in their paper they have used it in certain number of cases, and they have found that it has really helped in planning of the puncture, better understanding of the anatomy, and of course it has potential to reduce complications, and of course improving operative time, improving learning curve. So again, it's a very innovative and a right step in the right direction, truly useful for training. We really I think that 3D printing has become quite cheap now, so it should not be much of the cost issue, and we may have something similar in India sometime later. So the third paper, which is personally my favorite one, is a very good indigenous idea: percutaneous renal surgery access besides working guide wire. So idea is to, because see, all the senior surgeons, they really don't like keeping safety guide wire, but once in a while we have all faced that guide wire has slipped, and we have also slipped out of the system. But of course, keeping safety guide wire and putting another guide wire, it's a time-taking process. So how can one reduce that time, and how can one make their working guide wire into a safety guide wire without adding any additional step? So very nice view from Morocco. So this method can be used for RIRS, PCNL, for all kind of access. So they made a hole, puncture hole in the access sheath. They pass the guide wire roughly 3 to 4 centimeters away from the tip. They take out the guide wire from here, and when the sheath or the cannula is pushed further, the guide wire comes out and it remains in the frac. So same thing can of course be used in, so this is how it was slit so that the guide wire comes out, and same thing can be done in PCNL. And so of course Cobra catheter which comes with the Cook's dilator, that can be used. And even the stent pusher, they have used the stent pusher in order to create this mechanism. So how it is done, there is a 4 to 5 centimeter sleeve is cut from the pusher or the catheter, and afterwards in the end of the where the knife stops, and the knife is rotated in order to make a small puncture hole so that the guide wire moves freely, because from the sleeve it will not move freely. And again, the same mechanism as I showed, the same principle is followed. The guide wire is taken out from here, and when the amplas or anything is pushed, the guide wire becomes your working guide wire becomes your safety guide wire. And I guess they have also demonstrated it in the surgery. So that's how it is. It is they're using the stent pusher, so it's no cost issues at all. I mean, you anyways put stent, you always have a stent pusher at hand. And of course, once you dilate, then the stent pusher is passed, guide wire is taken out from the side hole, and when the amplas is pushed, and it comes out as a safety guide wire. So they've used it in certain number of cases, of course, and in short, it worked all fine, except the cases where there was perirenal fibrosis, because it could not allow smooth movement of the double J stent pusher. So something stiff like a Cobra catheter can be useful in that situation, and really saves time, and your guide wire remains safe and secure. So that's about it. And of course, dilatation is feasible and safe. It allows economy of time, radiation exposure, and of course saves a guide wire as well. And a slightly stiffer, more industry grade product will really make use of this idea better. We have seen this kind of indigenization in India as well, with various ways of doing it. And it of course fits most of our settings and the bills. Thank you so much, Dilip, for this opportunity.
Thank you, Aditya. It was a nice presentation. We made very good use of the videos. I would request MS Agarwal sir to give his comments, expert comments on these 3 papers.
Well, friends, thanks Dilip and North Zone for this opportunity. These are very interesting papers which Aditya has presented. See, these 2 futuristic papers, one on the intraoperative cone beam computed tomography. As Aditya said, there is a great potential to this concept of being able to identify fragments intraoperatively so that one can remove them and give the patient a stone-free status. And this is, as we all can see, a pilot project. They showed improvement, like they were able to remove stones only in 16% patients. But I'm sure there is a way to go, and the cost constraints which we perceive as of now, I'm sure they will be overcome. But it is essentially a step forward. And similarly, the idea of 3D printing of the anatomy and practicing on it, not only observing, looking at it, but also practicing the puncture, I think will be a great step forward for future learning. And I'm sure creating a model and practicing on it before you embark upon real surgery is something which is going to be the future of surgery, I'm sure, in not only in percutaneous renal surgery, but in many other fields. So I think we are just peeping into the future, and there is much more we are going to hear about these technologies in times to come. The third one is from Mohammed Lazarek from Morocco. And if you recall, he's one of the gentlemen we invited in the UCCon 2020 Kochi. He's a great innovator, and he keeps coming up with these small innovations here and there. He's done a lot of small things, and he's greatly into these low-cost innovations. So it is a good idea, and maybe we can learn many of these tricks. He's got a lot of videos on the YouTube and everywhere on the net about these simple tricks which you can do, creating a basket out of a net and so on. So I think you can watch this and see how you can use this working wire as a safety wire. It's a simple thing, but interesting. So I think that's about all that I would like to comment on this. And for the sake of moving forward, and we are already running behind time, I think I'll pass it on. Thank you.
Thank you, sir.
If I would ask for a small comment from Pal sir and Sood sir, if we would like to comment, sir.
Regarding cone beam, I am so concerned about the radiation exposure by CT scan. I don't even advise on the first, I always tell my patients that NCCT should be done only once in a year because it gives too much of radiation. So cone beam CT inside operation theater will give a lot of radiation to the team as well as to the patient. So ECIRS will be a better choice if there is a complicated stone. You better use the ECIRS. You use all of us are quite experienced with Flexi. We'll be able to see residual stones. That is what only my complaint, comment.
Sir, team goes out. Sir, team goes out when CT is done. Team goes out.
But still, you have to. Somebody has to be there watching it. And then, secondly, when you have to remove the stone, under the same guidance, you will have to repuncture or you have to renegotiate your instruments. So exposure will definitely be there. It is not that you will be just taking a picture. Regarding the guide wire, I saw the video. I could not understand it well. And if you are very keen to put a safety guide wire, so just when you are using the Elkin dilator, putting a safety guide wire will take another 5 minutes. That's all. So anyway, I'll have to see once again and learn how you can convert a working guide wire into a safety guide wire. I could not understand it well. Although videos are very high quality, but I have to see it again. Thank you.
Actually, Lazarek comes up with lots of small tricks like this. He's a very interesting guy.
I keep interacting with him very often.
Yeah, he runs a society called something like affordable technology or something.
Yeah.
So,
he comes from military hospital. All the jugards happen when you don't have resources.
So he's very much like us. Yeah. Okay.
Any comments from Sood sir, if possible, sir? Sir, you are muted, sir.
I think these are everything has been discussed. These are futuristic things for us who are practicing, and also as the concern for radiation was discussed by Dr. Pal, it is not only for the patient and the operator, but also for the paramedical staff also there, and who are not going to change frequently. And the other thing is that this about the guide wire, this looks very impressive, and this can be done. Dr. Pal is very, very experienced, so he can put anything anywhere, and certain things are there which can ease the procedure and can help. That is always welcome, and that can be experimented and also adopted wherever possible.
One thing which I noted in the first paper was that they even with the cone beam CT, they could attain a clearance of 63%, which is very Indian standards.
Because you can't always reach the fragment you may see, but you may not always go back and reach there.
Yeah, probably they need to learn from that.
Most of these people are happy with the clearance rates of 60 and 70%. In India, if you cannot achieve 98 or 99% success, you have no business to be in business. You have to leave urology.
Learn saline push. Saline push will give all clearance easily. Any
Yes,
small
we'll come to
fragment
that.
also you
Yes,
can
sir.
do that. Okay.
Okay, moving on to the next speaker. The next speaker is Dr. Avijit Kumar from Kanpur, the city which I did my MBBS from. I love Kanpur. So Avijit, on to you with your 3 papers. Next in line, Avijit. You're muted, Avijit. Yeah.
Yeah. Good evening, sir. I'll just.
You can share a screen, Avijit.
Yeah, I'm trying to. Is it visible, sir?
Yeah, it's visible. You can make it full screen.
Yeah.
Great. Go ahead.
Good evening, everybody. And thanks for the opportunity to present these few selected papers. So, so I'll be presenting 3 abstracts. The first abstract is efficacy and safety of one-step dilatation versus a serial dilatation for the percutaneous nephrotomy. This was a randomized control study, and this paper comes from Egypt. Now, as you all know, there are 3 main ways to dilate the tract during PCNL. One is the metal telescoping dilators, the Alchem dilators, which we routinely use. The others are the sequential facial dilators, and the third is the balloon dilator. The metal dilators, which are very common, they are reusable, economical, and have a tamponade effect. So helps in controlling the bleeding. And the sequential facial dilators also are the next commonly used ones. The only disadvantage of these 2 dilators would be that they are little time consuming, and the guide wire at times might get kinked, or we might enter a false passage. The third is the balloon dilator, which is quite expensive, and I don't have any personal experience in using it. So this aim of the study was to compare one-step dilatation and a serial metallic dilatation by Alchem for PCNL tract regarding efficacy and safety. So the authors regarding one-step dilatation, they said that it can reduce the chance of access failure, it can decrease the operative time, and decrease the exposure time of the radiation. So what they did was that they, over the period of 2.5 years, they had divided 130 patients prospectively into 2 groups. The group 1 patients underwent a single-step 30 French amplage dilator, and the second group had the serial dilatation from 9 to 30 French. The results were, when compared to group 2, the group 1 had statistically significant results in operative time. It was less as compared to group 2. The dilatation time, it was around 62 seconds. The total X-ray exposure time was around 162 seconds, and the total exposure during dilatation was also around 44 seconds. The hemoglobin loss and the hospital stay was also quite less as compared to the patients in group 2. So they could, and also the stone-free rates and the perioperative complications according to the Clavian grading system were comparable in both the groups, and they were not statistically significant. So among going into the literature, I could find a few more papers which had the same conclusion as the authors had, that one-step dilatation is quite safe, efficacious technique which can reduce access time, fluoroscopy time, and the hemoglobin levels. So they were able to conclude that one-step dilatation during PCNL is a feasible option, safe, and offers shorter operative time and shorter exposure to the X-ray with less amounts of blood loss. The second paper was regarding the efficacy of a local anesthetic infiltration around the nephrostomy tract on post-operative pain control after a tubeless PCNL. It was a meta-analysis of certain randomized control trials. This paper comes from China. Now they introduce the concept that there's actually no evidence to support the effect of local anesthetic infiltration in alleviating pain after a tubeless PCNL. So they conducted a meta-analysis to provide evidence on the analgesic efficacy of local anesthetic infiltration to prove to further improve pain alleviation after a tubeless PCNL. So they did a systematic review of literature, and out of 18 articles which were selected, they had 5 trials which they included in the study. The main outcome which they wanted to address was the duration of the analgesia measured by the time of first analgesic demand and the total analgesic consumption. The secondary outcomes was the VAS score at 6th hour and 24th hour. So among 284 patients, 187 of whom were men from 4 countries were considered eligible for meta-analysis. What they concluded was that the patients receiving local analgesic infiltration had less analgesic consumption and lower amounts of lower VAS 6th and 24th hour score as compared to the other group. But as regard to the total analytic duration, there was no difference. Another in literature, I could find an article which suggests that infiltration of ketamine and bupivacaine is supposed to provide a superior effect in PCL surgery as compared to other techniques. What the author concluded was that local anesthetic infiltration around the nephrostomy tract may be an efficient alternative for post-operative pain relief after a tubeless PCNL. The third and the last presentation, it was regarding renal pelvic pressure fluctuations during a vacuum-assisted mini PCNL. And may this technique help in reducing infectious complications? This comes from Milan. The authors suggested that the mini nephroscope which we use, it may cause a sudden rise in the renal pelvic pressure due to reduced outflow from the miniaturized access sheath. And the literature also suggests that renal pelvic pressure beyond 40 or 0.78 centimeters of water, it causes an increase in the black flow in the renal tubules, leading to an increased incidence of infectious complications. So what they used was a vacuum-assisted mini PCNL, which was supposed to lower the renal pelvic pressure by suctioning the irrigation fluid during lithotripsy. So the aim of the study was to evaluate renal pelvic pressure fluctuations during a vacuum mini PCNL. So they prospectively collected data from patients who underwent PCNL from March to September 2019. All the PCNLs were done in supine position, and they had used this 16 French clear Petra nephrostomic sheath with a lateral aspiration arm, a 12 French Stowe's nephroscope, and a holmium laser. They had all used an irrigation bag which was around 1.5 meters above the kidney level. And the measurements of the renal pelvic pressures was done by an open and ureteric catheter, the other end of which was connected to a transducer of a urodynamic machine, which was taking measurements. Around 50 measurements were taken per second. And the stone clearance they had assessed was after 2 to 3 months by a CT scan and ultrasonography. So they had included 20 vacuum mini PCNLs in the study. The parameters of the stone were like median stone volume was around 1.24 centimeter cube. The mean operative time was around 83 minutes. The median lithotripsy time was 17 minutes. The mean renal pelvic pressure during the procedure was around 15.4 centimeter of water. And during lithotripsy and suction mediated lapaxy, these are the two durations during which there is supposed to be a sudden increase in the renal pelvic pressure. So at this moment of time, the pressure was only 13.3 centimeter of water. So among all the procedures, only 3 procedures had shown a pelvic pressure of more than around 40.78 centimeter of water. And the median time of this rise was around 28.5 seconds. So what the results were, like the maximum peak of renal pelvic pressure which was reached during the surgery was on these 3 instances. One was when the pylographies were done in 55% of the patients. This is the time when the RPP was more. Other time was nephroscopies and close aspirations in 35% of the patients, and during puncture in 20% of the patients. Among all the patients, 2 experienced Clavien 2 complications. One had a transfusion and one had a fever treated with post-operative antibiotics. And the stone clearance was around 77.8%. So among 14 patients had a complete stone clearance out of the 18 patients. So among literature also, there were few more studies who were of the same conclusion of what the authors said. And this IRP is intrarenal pressure, and they suggested that IRP of more than 20 millimeter of mercury and accumulative time of more than 50 seconds were correlated with an increase in post-operative fever and infectious complications. So what the authors concluded was that vacuum mini PCNL was characterized by low renal pelvic pressures. The maximum peak in the renal pelvic pressures reaches while the aspiration is closed. And as compared to the standard PCNL, on these 2 instances during lithotripsy and vacuum mediated lapaxy was a time when the threshold rose above 40 centimeter of water. It never happened in this vacuum assisted mini PCNL. And infectious complications also appear to be on the lower side. Thank you.
Nice presentation, Avijit. You have saved us 1 minute. You have done it very concisely and very clearly. Thank you. I would like to invite comments from Rajiv Sood sir on these 3 papers.
Thank you, Dr. Dilip. These are great papers and very good topics for usually we give for thesis also on PCNL to different PG students. And these are the studies which are based on our earlier observations also, which we are doing like stage dilatation. That balloon dilatation was always giving all the benefits, but it was not much practice because of cost. And ultimately, we know that these problems of which we face during these serial dilatations and others of kinking, displacement, and fall passages, which has been projected in this paper, they are important, and they are to be avoided. So single dilatation, even the short dilated track, that can be there. These all are to be avoided, and the results are as expected, that even the dilatation time and outcomes, and even pain and other outcomes are better with the single stage, we know. And that has been proved in the first paper. Now coming to the second paper. Second paper is about the efficacy of local anesthetics. Now this paper, and they have quoted several studies where a couple of hundred patients have been segregated, and they have been told that what has happened. In fact, this all operative wounds and plastic surgery and other surgical procedures, not only post-operative, pre-operative infiltration with bupivacaine was experimented and is proven. It is in the guidelines, both in the requirement of post-operative analgesia requirement, as well as in the the visual analog score for pain, which has shown benefits in the open surgery, plastic surgery, everywhere. Now coming to the disadvantages which were thought earlier, that are also dispelled away, because we know that bupivacaine which is used, that is also bacteriostatic and bactericidal. So that having that knowledge with us, this is always important. And of course, we may not need in this, but we have seen in our open surgery and even our plastic surgery colleagues, they are using different pumps also post-operatively. They put some catheters, they use new formulations of these analgesics, like liposomal microcapsules or charged particles. And also there are tumor sense techniques which we can also use. We are also doing reconstructive surgery, plastic surgeons are using, that is the low quantity of analgesic, and plus a large amount of volume of the diluent. And also we give this make the tissue tumescent, and that improves the healing. And I forgot to mention that with this we are decreasing the inflammatory reactions also. So when we apply it on tubeless PCNL, in this case, that is very, very important, and we should use it. And it is not giving, our myths are there that infection may come or some problem. In fact, it will help healing post-operative pain. And if you have manipulations, a lot of manipulations have been done, that is important, that we give this local anesthetic. Now coming to the last paper, which is really interesting, because we know that in the close, the resting pressure may be 0 or 10, and if the system is obstructive, and you give even mannitol or diuretics, the pressure increases. Maybe there are studies where sometimes the pressure becomes after mannitol 17, or it may go to 35 if the hydronephrosis and obstruction is there. And we know that rigid scopes, flexible scopes have difference in increase of intra-pelvic pressure. Like flexible nephroscopes, they increase the pressure less. Multiple tracks also increase the pressure less. Therefore, keep the pressure low. That is what is proved in this paper also. We are benefited as the incidence number will go down, incidence of infections, the tubular backflow, that all will decrease. And because the timing, as has been mentioned in the paper, that is also important. That is around, I think, 28 seconds, which is much below the given threshold, that to what level that should be there. So on all the aspects, we are better placed if it is actually the rigid scope, it is the mini scope, the pressure can increase, and especially when your tip of the scope is not properly placed, or there are other problems. So keeping pressure low with this additional assistance with this vacuum assisted, and they will increase the renal pelvic pressure fluctuations at lower side, and for the shorter time the higher pressures, and therefore for the infection problems are obviously low. And as we know that even in ureteroscopy, if you are using the sheath and all, there is a pressure is maintained, and pressure is not rising to 30, 35 or 40. But here, when there is likelihood of increasing of pressure, this is very good means, and we are benefited as shown in the paper, and this is very good.
Thank you, sir. I would like to have a quick comment from Pal sir and Madhu sir also on this.
Well, if I would like to add anything, it will be on the last one. We have seen that there is a definite benefit of the adding suction to the mini PCNL sheath, and we have super mini PCNL, the super perk, the indigenous sheath which has been produced by our friend Kaushik Shah, and I think this is a great step forward in mini PCNL technology. So this is something which most of us have found beneficial, and I'm sure this is a great feature. That's all I have to add.
Also, please, sir.
Regarding the single step versus this multi-step dilators, see, I presume from skin to the renal capsule, everything is liquid except three things, three places. One is skin, second is lumbodorsal fascia, and lastly when you are entering the renal capsule. These are the three places where you encounter resistance. Otherwise, kidney parenchyma is very fluid, it's very innocent. So whether you pass a single step thin dilator or a large dilator passing through butter or passing through water, it doesn't make any difference. Only at these three places you have to be careful so that your guide wire does not come out by angulation or does not get kinked if it is not a terumo. So these three places, otherwise there is no difference whether you use a single step. Definitely when you are using single step, the time duration will be less. Regarding clearance, stone clearance and all, doesn't matter whether whatever way you dilate, the clearance remains the same on your expertise and the availability of the things. The last paper on the suction, definitely suction reduces the pressure and complications are less, but at the same time, suction should not be so much that it collapses the system completely. Visibility inside the system, sufficient visibility inside the system to pick up the stones easily or remove the fragments completely is very important. If it collapses completely, the stones may get missed here and there. And secondly, if you try to remove without viewing them nicely, properly, you may injure the renal mucosa, the mucosa inside, and there will be more bleeding. So there has to be a very nice balance, particularly infected case, first puncture and aspirating pus. Definitely you have to maintain the this pressure very low by whatever means you can. So this is a nice balance you have to maintain with the suction and without suction. Thank you.
Thank you, sir. I don't think I need to add anything because all the experts have added very nicely on all the three papers, which are really different from each other. Next, I would like to invite Dr. Sudhir from PJ Chandigarh, who is going to present his three papers on PCNL technique. Dr. Sudhir?
Sir, am I audible, sir?
Yes, yes, you can see your slides. You can go ahead.
Good evening all. Respected seniors and dear colleagues. I thank Dr. Dilip Mishra and Dr. Anup Kumar for giving me an opportunity to be a part of this great online CME, and which particularly in my area of interest for updating my knowledge in endourology. So my job is on presenting papers on PCNL technique. So the first abstract is from Russia by Enikiv et al. It's basically a first clinical experience on super pulse thulium fiber laser in removing kidney stones. So as we all know that holmium laser is the gold standard for stone ablation now, and with the improved technology in the holmium laser dusting technique by the Moses technology as well, the efficacy of holmium laser has improved further. And of course, the main disadvantage of holmium laser per se is the retropulsion rate, which further increases the operative time as well as the decreases the stone ablation rate. So to counteract this retropulsion problem, a new laser which has come up recently, which everyone of us know, that's the thulium fiber laser. And basically, majority of the studies done on thulium fiber laser were in vitro studies. So as of now, the clinical data on the outcome of this laser in stones is not available. So with the objective of evaluating the efficacy and safety of super pulse thulium fiber laser during PCNL, this paper was done, this study was done. And stones with less than 2.5 centimeter in size were prospectively enrolled. And the Eurolace 2 is a machine which was used for ablating the stone. And all the various parameters related to the PCNL, particularly their laser on time, was specifically recorded. As usual, the stone free rate and residual fragments, they are actually evaluated by a post-operative CT scan. And as we expected, obviously, with this, the stone clearance rate might be less because it will pick up even the small fragments as well. The complications using Cleveland integrating and the stone retropulsion and the endoscopic visibility was also specifically assessed from the surgeons using a questionnaire. So this is the data of around 137 patients who underwent this procedure, and the mean stone size you can see is very less, around 12.1 plus or minus 7.4 mm, which is lesser. And the mean operative time was around 27 minutes. And you can see the mean laser on time was around 6.5 minutes. I was surprised to find a 1 minute laser time in one of the cases. I don't know, because we didn't have the exact data. They have mentioned that it ranged from 1 minute to 45 minutes. So the stone free rate was around 85% and the overall complication rate was around 17%. And the most commonly used laser settings in their study cohort was for dusting, they used the 0.15 joule to the 0.5 joules with a frequency ranging from 30 Hz to 200 Hz. Whereas for fragmentation, they have used the 0.8 joule and the 31 to 38 Hz frequency. So as the questionnaire from the surgeons, feedback was collected, you can see they mentioned that the surgeons reported stone retropulsion, which interfered with the surgery in around 1.4% cases. There is some insignificant retropulsion in around 11.7% because the super pulse thulium laser was mainly propagated to that it has a very less retropulsion rate. So they have specifically looked about these areas. And poor visualization in 5.1% of patients, and in 9.5% patients, minor visibility was there due to visibility. Because in India also, majority of the people who use this laser, they frequently complain that sparking will be there inside, which sometimes hinders your visibility. So they concluded that super pulse thulium fiber laser is safe and it's an effective modality for lithotripsy during PNL, and it results in minimal retropulsion. And of course, further studies comparing it with holmium laser are warranted in future. Coming to the next abstract, it is actually an experience from multi-center over a 20-year period on percutaneous nephrolithotomy in transplant kidneys. Of course, from 3 centers in Europe, they have collected the data. So as we all know that PCNL in transplant kidneys has unique endourological challenges owing to the pelvic position of the kidney. And to demonstrate the safety and feasibility of this PCNL in these kidneys, they have done this study. So it was a prospectively maintained data from 3 high volume centers, as I already told, over a period of 20 years. And of course, the basic data of stone and the technique and outcomes have been recorded. A total of 17 transplant PCNLs were done during the study period. And all patients, as expected, they are done in a supine position. And the most common position is the standard supine position in 10 patients. However, in rest of the patients, modified Valdivia position and lithotomy position were used. And right side being the most common site of the stone. And in majority of the stones, renal pelvic stones were there, whereas in 3 patients, stones were there even in the ureter as well. And for puncturing, yes, ultrasound and fluoroscopy have been used individually, but frequently the combination of both were used. Of course, lower polar puncture is the most commonly done puncture in their study cohort. And the technique which they have used is the combined approach in 6 patients, like both endoscopically from below and from antegrade using PCNL. So that has achieved a stone clearance in 6 patients. Of course, they have done staged procedure in 3 patients. The fragmentation, yes, they have used both the lithoclast as well as laser, and some stone fragments have been taken out as such as well. So in all patients had post-operative nephrostomies, and 3 patients had stents. So coming to the results, around 17 patients with a median age of 51 years, and you can see the mean stone size is ranging from 7 to 60 mm. And the median operative time was 65 minutes. And one doubtful data which they have provided here is, if you see the median fluoroscopic time, they have mentioned it from 31 to 372 minutes. However, the range in the overall median operative time was 30 to 120 minutes only. So I somehow feel that this 372 minutes would be some wrong data here. But overall, the median fluoroscopy time was 84 minutes, which is significantly higher. And stone clearance rate was around 14 cases. They have stone clearance to the tune of 82%. And only 1 patient they mentioned they had a complication of the Caven-Glindo of around 3A, but none of the patients received any transfusion. So they concluded that PCNL is safe and effective in treating nephrolithiasis in transplant kidneys. And compared to the outcomes with the contemporary native renal PCNL data, it is comparable. And combination with ECIRS is preferable because this avoids multiple punctures, particularly in renal allograft. So supine PCNL also they propose that it enables the ease of access for ECRS as well as the iliac fossa kidney. And they suggested that in their experience that surgical centers with high volume where a dedicated transplant and endourological expertise is available should be best for treating such type of stones. Coming to the final abstract, it is basically on super mini percutaneous PCNL compared with miniaturized PCNL, particularly in stones more than 2 centimeter size. So this is actually a comparative study. Of course, as we all know that super mini PCNL is a modification of the mini perc, where you will be having the added advantage of suctioning the stone fragments as well. And they compared this with the standard miniaturized percutaneous nephrolithotomy, particularly for treating more than 2 centimeter stones. So if you, just for the sake of revision, I have put up these photographs of super mini PCNL. You can see the nephroscope will have a 3 French fiber optic telescope. That is a major advantage of this scope, because it is just out to the size of a 1 millimeter in size. And obviously there is a 7 French outer diameter as well, which will provide a space for the irrigation fluid to go in and out. Then there is a modified nephroscope, the Amplus as well, with a side tube for suctioning the stone fragments immediately. So this is a multi-center retrospective study comparing both the techniques. And of course, all the data regarding to stone were compared. The most important thing which they have done is they have done a propensity score matching for both the groups. So after propensity score matching, around 1,380 patients were there in each group, which is a very high number. And they found that the stone burden is comparable in both the groups, and also the mean operative time was also comparable in both the mini PCNL versus super mini PNL, whereas the stone free rates in the post-operative day 1 were significantly higher in the super mini perc compared to the other group. But at 1 month, in both the groups, the stone clearance were comparable. And they have shown that super mini perc has a higher tubulous rate, whereas the post-operative fever was also higher in mini PCNL compared to the super mini perc. But there is no statistical difference between the blood transfusion rate, but they mentioned that 5 patients in super mini PCNL group and 12 patients in mini PCNL group, they required renal embolization for massive hemorrhage as well. So that is a important data in their data. And coming to the hospital state, as usual, since the tubeless rate was higher in the super mini perc group, the hospital rate was lesser in them significantly. So they concluded that super mini PCNL is safe and efficacious for treatment of stones, particularly more than 2 centimeter size. And of course, it is equally effective as mini PERC, particularly in moderate renal calculi, with the basic advantage of tubeless rate, higher tubeless rate, less hospital stay, and less post-operative fever. Thank you.
Thank you, Dr. Sudhir. Nicely presented all three abstracts. Now I would like comments from Pal sir.
See, regarding paper 1, it is very well understood now that TFL is a very good laser, where the more amount of energy is being delivered per square millimeter area in comparison to the holmium laser. Much higher percentage, and it's therefore with a very thin fiber we are able to deliver very high energy. So with this, definitely when there is high energy being delivered, the retropulsion, and with a thinner retropulsion will be less, and that is what has been experience of everyone whosoever is using it. Also, it is very much useful, particularly for the RIRS procedures in comparison to PCNL, where you have a big working channel from where you can work with both the lasers. And retropulsion also is not so important a drawback, particularly in PCNLs, because you have a wide area, you can walk down up to the stone and you can remove. So if you can afford it, definitely it is a better laser for both the techniques. Regarding transplant kidney, see, none of us can claim that we are expert in doing a PCNL in a transplant kidney. Hardly ever we get a chance. I have only one experience of a PCNL in a transplant kidney. Transplant kidney is a super precious kidney. Even otherwise, PCNL being a blind procedure and you don't know what you are going to land into. So in this case, you have to be really very careful when you are going to do it. You must do a CT scan of abdomen before to analyze that there is no bowel loops over the transplanted kidney. It is a well protected kidney from behind with the iliac crest, and therefore it should not be, in my view, which I have done, it should not be a supine PCNL, supine patient completely. You should put something below the buttock to tilt the patient so that the bowel moves away. At the same time, you should always keep because these are immunocompromised patient, and also if there is a stone and there is some infection or obstruction, again the renal failure component is also going to trouble you. So you have to be very safe. So you should always do a CT scan, analyze skin to calyceal distance, analyze that there is nothing in between, see the approach which you are going to make, and always tilt the patient with a buttock, with a something below the buttock so that the bowel moves away. And if possible, or I will say that you should have a ultrasound inside the operation theater when you are doing a PCNL on a transplanted kidney. So all precautions must be taken. And if it is a small stone, it is better to resort to RIRS rather than going to venture a PCNL in these cases. Lastly, there is hardly a difference between super mini PCNL, and this is only the definition which is very confusing. Super mini PCNL is ranging from 8 to 10 French, and anything from 14 to 22 is considered as a mini PCNL. There are no clear-cut definitions. And if you go through an artery, whether you make a hole of 8 French or 18 French, if you have perforated the posterior segmental artery, the bleeding and even if you have perforated the colon, the complication rate will remain the same. So as such, super mini PCNL, because we know that the bleeding complication rate of the renal parenchyma, not going through the vessel, is less because the area, the diameter of the injury being created in the PCNL is smaller. So blood transfusion rate is less in smaller the diameter. And also when you are adding the suction component, the pressure will also be low. So super mini PCNL appears to be much safer. But at the same time, we have to remember, and we have to take it with a pinch of salt, that it will be quicker to remove the fragments. The fragments will be much smaller to be removed from a smaller track. more number of stone fragments to be removed. So both the techniques are good. You have to choose according to your expertise. Both have almost similar complication rates, and whatever you have and whatever you expertise, we should choose that particular technique. These are my comments for these three papers. Thank you.
Thank you, sir. Thank you, sir.
Can I add a point?
Yeah, go ahead, Sid.
Just as Dr. Pal sir has suggested that for a vascular injury, even a small tract also can lead to a significant amount of bleeding. So I'm happy to just say that one of the recently we have done a randomized controlled trial comparing the standard PCNL and also mini-PER, which was actually recently accepted for publication in Journal of Endourology. Where we also clearly have shown this point only, that mini PCNL and standard PCNL, so far as the puncture is good, then obviously the chances of bleeding will be lesser definitely with mini PCNL. But the moment if you have done a wrong puncture, then the major bleeding would ultimately could be either ways. It could be even equal as well. In our study also, we have shown that the blood transfusion rate were comparable in both, because even in mini PCNL patients also, in few patients they had a significant amount of bleeding. So just to re-emphasize the sir's point, which sir was telling, I want to just add that point. And coming to the thulium fiber,
anatomically analyze it from where the bleeding occurs. It is through the renal parenchyma, which is supplied by thin vessels. Even 30 French tract, it was not a very significant bleeding when the 24 and 27 nephroscopes are available. We had no choice but to make a bigger tract. And second part is, if there is a vascular injury, whether you go through the vein or artery, then whatever it is, whether it is a small or a big injury, it will bleed. Thirdly, it can happen with the mucosa. If you go inside the pelvic calyceal system and then injure the mucosa, there is sometimes a very significant bleeding intraoperatively taking place on your face through the mucosa itself, which sometimes stops on its own. So the only bleeding which can differ is the renal parenchymal bleeding with the tract size.
Yeah.
Regarding vascular injury, vessels, vein or artery, or through the mucosa, bleeding will remain same. It is because of an accidental injury to the mucosa or accidental passage through the vein or artery. That will remain same in both the situations.
Madhu sir, any comments, sir?
I think this debate about the tract size and complication rate of bleeding is never ending. So I think we need to move forward. All I would like to say here is that the super pulse or the TFL is probably the laser of the future, and we have to learn more about it. So maybe we'll do more and more of those. And the SMP or the super mini PCNL is PCNL with added suction. Actually, by definition, that is similar to our super PERC, which Dr. Kaushik Shah has. So maybe adding suction and reducing size is also the way forward. So we need to go on exploring the new frontiers and come up with the advancements in technology as we go forward.
Thank you, sir. Any comments, sir? Rajiv Sood, sir, final comments.
I think everything has been said by the experts, Dr. Pal and Dr. Madhu. And when it comes to holmium versus thulium, in our department, we prefer to procure thulium laser. And that is the choice after going through and watching and observing the experts for long. And we are happy. That second is about this transplant surgery. You see that in the transplant kidney, the PCNL, they had collected, I think, from 3 different countries, the cases. So it is just like presenting the rare case. When you operate on that in your meeting, monthly meeting or annual meeting, you will be presenting that case and you will be giving your experience. It is not something which will give uniform lesson. It is individualized operation for that person. And as has been amply explained by Dr. S.K. Paul, that kidney's anatomy is not normal. And you have to see that what bowel or what all relations are there. And it is very tricky operation. is to be presented and shared every time anybody comes across that. And that is all mini PCNL, everything has been said. Thank you.
Only good thing about transplanted kidney is that the vessels are very deep. Artery and vein are too deep. You cannot endure going so deep inside, means the main vessels. So that is one good thing about this transplanted kidney.
Okay. Can I add a comment about the transplant kidney and PCNL?
Sure, sir. Sure, sir. Please, sir, go ahead.
Yeah, so we have not a large experience, but about 6 cases in such a large series of about 3,500 transplants, and some more coming from outside. So the basic fundamental which we all need to understand is that 90% are the left-sided kidneys. Our programs are generally live related, and we take the left-sided kidney, and usually everyone puts it into the right iliac fossa. When I had my training way back in 1996 in England, then there was a complete fuss about the right kidney to be put in the left fossa and left in the right for some consultants. And if you see the older textbook of Peter Morris, there are other kinds of fundamentals given. But now we all put unanimously, whether it is right kidney or left kidney, into the right fossa itself. Now, when you put the left kidney into the right fossa, it is 180-degree reversal. Therefore, the calyces, when you go supine, your relationship remains same, because posterior calyx, easy and straightforward for the prone position, becomes the same because the kidney is rotated by 180 degree as you place it. So supine and posterior calyx, they would be in line. This is about the left kidney. And usually the punctures are done ultrasound wise. So we don't really need a CT scan unless, if you are suspecting something else. And bowel can be easily avoided. Yes, you could do a bit of positioning, maneuverability in the positioning. When it is the right kidney, which is also put into the right fossa, as I said, now everything is put into the right fossa, unless in some cases, then again we need to see that this kidney has been positioned similarly, and therefore the anterior calyx and the posterior calyx has now got a to be understood a little bit more. But generally, if you go through an upper calyx taking care of the bowel, then it doesn't matter. So it's not very difficult, and we don't need to have a lot of issues or concerns about the PCNL in a transplant kidney. They are very superficial. 1 or 2 centimeter you go in, you will get into the system, especially if it is dilated. Thank you.
Thank you, Anish sir. It was a very welcome comment from you, because you are the best person to give a comment on PCNL on transplanted kidney. And with this, I would like to thank all my experts who have spared so much time. As Kepal sir was busy in another webinar, but still he spared time for this. Thank you, sir. Madhu sir also, and as well as Rajesh sir. I am sorry, sir, I couldn't send the right abstract to you in right time, but still. So thank you, everyone. Now we will move on to the last and final session, which is on RIRS. And I would invite our next set of experts. Anish Srivastava sir already has given a very beautiful comment on transplant kidney. And Dr. S.P. Yadav sir is our next expert. And most importantly, Dr. Anil Shrestha, who is joined all the time, given all us so much time he's joined from Nepal, and he's giving all the time. We have been seeing him since the start of the program. Thank you, Dr. Anil. So I would start, go ahead with this RAS session, and I would invite Dr. Lakshmikant. Is he here? Dr. Lakshmikant?
Am I audible, sir?
Yeah, you're not visible, but you're audible, but not visible. Yes, Lakshmikant, you can go ahead, share your slides, and you can go ahead with your abstracts.
Good evening. Good evening, all. Thank you, North Zone and Dr. Dilip sir for giving me this opportunity. My first presentation is on the assessment of transient ureteral stenting by ureteral catheter after primary ureterorhinoscopy and stone extraction, which was a prospective randomized study which was done in Germany by A. Reach Herne. So they had evaluated the outcomes of short-term ureter catheter placement compared to the conventional DJ stent placement following URS. So they had included the patients with the renal or ureteral calculi, and they randomized prospectively it into the two groups prior to primary URS. First group, they had inserted the ureteral catheter for 6 hours after URS, and in the other group, DJ stent was inserted for 3 to 5 days. So the exclusion criteria were acute UTI, patients having solitary kidneys or stone diameter more than 25 mm. And the endpoints, they evaluated the endpoints were the reintervention rate and the stent-related symptoms, which were assessed by the validated questionnaire and the visual analog scale 1 day after the intervention and 3 to 5 weeks after the surgery. So the results of the study were more than 90% patients had stone removal in all the patients, and mean operative time was 25 versus 20 minutes, and stone size was 5 versus 4.5 minutes for ureteric catheter versus DJ stenting respectively. 1 day post-operatively, the ureteric catheter group significantly benefited from the LUTs compared to the DJ stent group, although the pain index did not differ. After 3 to 5 weeks, there was no significant difference in the pain or the micturition symptoms was reported. So the reintervention rate was 22% for the DJ stenting and 32% for the ureteric catheter group, respectively. So they had concluded that 29% of the patients were not eligible for primary URS because of the exclusion and short-term ureteric catheter insertion following primary URS, resulting in a high revision rate, which was not significant. So in the literature, I have seen that stenting reduces the number of unplanned return visits, pain, and need for secondary interventions and ureteral stricture rates. Now coming to the second abstract, which is the study comes from the Southampton, UK, done by Petro Paulo, which is apnea is not necessary for flexible URS and RIRS of renal stone. This was a prospective study done over 6.5 years. So temporary apnea during RIRS was suggested and often practiced, which reduces the potential movement of the kidney secondary to respiratory movements. The aim of the study was to look at the outcomes of the RIRS for patients understanding the procedure under a GA without the use of apnea. So over a 6.5 year period from March 2012 to June 2018, consecutive cases of adult RIRS were recorded in a prospective database, and patient underwent surgical and anesthetic counseling, preoperatively assessment, and protocol-based general anesthesia without the use of apnea. Data on patient and stone demographics, operative details, and stone-free rates and complication rates were collected and analyzed. So the results were the 292 patients underwent RIRS, and pre and post-operative stent was placed in 28% and 81% of the patient. The mean single and cumulative stone size were 10.2 and 14.3 mm. For the mean operative time of 48 minutes, the stone-free rate was 88%. There were 11 complications which led to delayed discharge, of which 9 were Clavin 1 and 2, and 2 were Clavin 4. The Clavin 4 complications were 2 patients admitted to ICU for urosepsis and respiratory failure each. So these were the Clavin 4 complications where patients had 2 patients had urosepsis and 2 patients have respiratory complications. Now, they had concluded that RIRS can be safely performed without respiratory apnea using anesthesia and surgical protocols. It seems to improve daycare rates for RIRS and decrease the overall length of stay. And the patient expectation and counseling were along with good anesthetic and surgical cooperation during pre-assessment, surgery and post-procedure helps to improve RIRS outcomes. But the literature says that the use of apnea during RIRS has facilitated the procedure, which avoided the renal movements, particularly in special cases where extremely precise maneuvers during laser use are required. Now coming to the third article, which was how to identify an easy RIRS surgery to be performed by a NAVE resident in defining a training program. This comes from the Italy, and the aims of the study were to evaluate the ability of the stone-free rate in predicting the complexity of performing RIRS and to design an original standardized classification system of kidney stones suitable for RIRS and to evaluate its ability in predicting the absolute difficulty in performing RIRS and to create a nomogram. So they had evaluated 308 consecutive patients who underwent RIRS. All procedures were performed by the same person, same surgeon, and they collected data regarding age, size, location, composition, hardness, number of stones, and any previous ureteric procedures and any ureteric stent. The surgeon was asked to assign a degree of difficulty, classifying each RIRS as easy or non-easy to perform, whether by a NAVE resident or a non-skilled surgeon. So they had given points from 1 to 12 based upon the size of the stone, less than 10 mm to more than 10 mm, location of the stone, whether the stone is in the pelvis or pelvises, hardness of the stone about the less than 500 ounce field unit or more than 500 ounce field unit, number of the stones, upper urinary tract morphology, and ureteral morphology, and any previous procedures. And they had given the points from 15 to 20 in case of easy procedures, and 20 to 30 in intermediate procedure, and difficult procedures they gave more than 30 marks. So results were that RIRS were subdivided into 81 cases of grade easy and 135 cases of grade non-easy. So logistic regression demonstrated a significant correlation with different level of difficulty for size, location, hardness, number, upper urinary tract morphology, and ureteral morphology. Using these coefficients of a single significant variable, the nomogram was developed, and they had concluded that the stone-free rate is not a good indicator of absolute difficulty of renal lithiasis. The freshness of our of their novel scoring system is its focus on the absolute difficulty of the actual surgical procedure. They derived the nomogram, which allows the identification of the easy procedure suitable for NAVE urologists or residents to run, and but the external validation is required for this nomogram. Thank you.
Thank you, Dr. Lakshmi. You have had a variety of papers on RIRS and you have presented them very nicely. Now I would like to have comments from our SP Yadav sir, our expert comments.
Thank you, Dr. Dilip.
Yes, sir.
Lakshmi has presented very nicely. Can you hear me?
Yes, sir.
Hello?
Yes, sir. Yes, sir. Yes, we can hear.
Lakshmi has presented very nicely, and honestly speaking, if you look at the first paper, where the ureteral catheter versus stent catheter for 4, 5 hours or 6 hours, and stent for 2, 3 days. Look at the literature. I agree with him. There's hardly any difference, particularly for an uncomplicated case. But in a complicated case where there is a stricture, where there is a trauma, where there is a bleeding, it is better to put a stent. We, in practical life, we are 2 urologists working together, and one is very fond of putting a ureteric catheter for 4 to 6 hours, and I put a stent. We don't find, really speaking, much difference as far as outcome is concerned. This is as far as the ureteral stent in personal life is concerned. But if you look at the symptoms in terms of dysuria, frequency, burning, pelvic pain, back pain while passing urine, particularly in a patient who is beyond 45 or 50, the stent is more troublesome, honestly speaking, is more troublesome than the ureteric catheter. So the final comment, as far as I am concerned, in a complicated case, it is better to put a stent. In an uncomplicated case, it is your choice wherever you want to do, whether you put a stent or not, whether you put a ureteric catheter or put a stent. Regarding the second part, the apnea. Apnea, he has presented very nicely. The literature says hardly any difference statistically. But in practical life, while doing URS and particularly RIRS, if the patient stops his respiratory movements, if he's in spinal anesthesia, or if he's under GA and respiratory movement has stopped, the outcome is slightly better. But looking at the number of complications which have been mentioned in the literature, which practically we are not seeing, like pneumonitis, like effusion, like bronchitis, like pneumothorax, at least we have not seen in the last 4 or 5 years any case of pneumothorax or bronchitis or COPD increasing after using apnea in case of RIRS. But looking at the literature, these complications have been mentioned. In practicality, I personally believe and feel a short-term apnea does help you in doing RIRS, particularly while you manipulate the laser wire inside. When you bend it up and down and put a laser wire and the patient take a deep inspiration, then there is a problem. And if you do stop the respiration, then you are definitely slightly better off. Regarding the third part, the paper has been nicely presented, and it doesn't require, honestly speaking, we should do a young urologist while starting doing RIRS. You all know the scoring system. The score is definitely very helpful, particularly in a teaching institute. If there is a stricture, if there is a narrowness of the ureter, if there is an acute angle, if there is a long infundibulum, if there is a tight infundibulum, naturally the young urologist will find difficulty. Same way, if you put a DJ stent and do after 2 days or 2 weeks, definitely a young surgeon will be more comfortable in learning the RIRS if you are going after 2-3 days or 2 weeks. Hello?
Yes, sir. Yes, sir.
So I think the paper has been very nicely presented by Lakshmi, and apnea, ureteric stent versus ureteral catheter versus stents, and the how to train the young urologist has nicely been covered. Thank you, sir.
Thank you so much, sir. Thank you so much, sir. Yes, Dr. Anil, please go ahead.
Can I make a small comment, Dr. Dilip?
Yes, please.
Regarding apnea in RIRS, actually, the routine use of apnea for treatment of renal calculi is not necessary, actually. It should be used, or it is, commonly used when you need to do some precise incision of diverticular stones or endopyelotomy. For stones, yeah, obviously, if the movement of the kidneys are, we can lower the movement, I don't say you have to stop the movement. If you lower the movement by decreasing the respiratory rate, then you become more comfortable. So, but keeping the patient completely in apnea is not routine practice in my center.
Routinely not required.
So if you are doing precise incision like in endopyelotomy or cutting the diverticular stone infundibulum for the diverticular stone, then apnea is required.
Thank you, Doctor. And, yes, sir. I was coming to you, sir. Yes, sir. Please, sir.
Yeah. It is
Dr. Anish, sir.
Third paper is actually the best, I would say, because the authors have tried to develop a nomogram, which is actually the need of the day, with more number of postgraduates and trainees, young consultants, and lesser opportunities. Obviously, it's inversely proportional to the number of candidates. So we really need to have, something like this. We have many in PCNL, in laparoscopy, and this is the time when we should have in RIRS also, because all said and done, this procedure also can be fraught with serious complications rarely. But of course, they have admitted that they need external validation of this study. But I think they have nicely defined the characteristics.
Right, sir. You're very right, sir.
The normogram developed is very nice, sir.
Yes,
you look
sir,
at the total picture of the normogram, it is very nicely presented.
Yes, sir. So
in the paper.
Now I would thank you very much, sir, for all the comments. Now I'd like to our next speaker, Dr. Brushabhanu Nayak, who will present his another set of 3 abstracts on RIRS. Dr. Brushabhanu. We cannot see you. Dr. Brushabhanu, we cannot hear you. You're muted, I guess, and can't see you as well.
Can you hear me now?
Yeah, go ahead.
So good evening. At the outset, I'd like to thank Arjun and Dr. Dilip for asking me to present 3 abstracts for this particular session. So the first abstract is actually cost efficiency analysis of reusable versus single-use flexible ureteroscope. And the introduction was the current generation of single-use flexible ureteroscopes have demonstrated similar clinical, optical, and ergonomic efficacy compared to reusable flexible ureteroscopes. The objective of that their study was to compare the cost between single-use flexible ureteroscopes and the reusable flexible ureteroscopes. It was a retrospective review for use and cost of reusable flexible ureteroscopy. The study was conducted from March 2016 till October 2019. The number of procedures and the repairs were taken into account to calculate the cost per case. So when coming to the results, over a period of 44 months, they have actually done 749 procedures using the reusable flexible ureteroscope FlexXC of Storz with 32 repairs. When you look at the cost, to begin with, the reusable flexible ureteroscopes actually are highly costly. But as you go on and do more number of cases, when the number of cases you reach around 155, the cost of the reusable flexible ureteroscopes actually balance out to that of the litho view of a single use. And when you reach to around 274, the cost actually balances out to that of the fusion. So after around 400 cases, what they found, the average cost per case for reusable flexible ureteroscope around 480 pounds, whereas that of fusion and the litho view around 650 pounds and 950 pounds. So what they are trying to tell, if you using the reusable flexible ureteroscope is actually cost effective in the long run with once you do more number of cases. The second was the laser lithotripter setting according to the endoscopic view. How can we optimize the outcome? A simple way to optimize the treatment strategy, which was from Italy. The stone components and physical properties are important data in setting the laser lithotripter and choosing the correct fiber. The objective of this study was to investigate the hypothesis if an endourologist with a knowledge in the crystallography can actually foresee the stone composition while doing the procedure, endoscopic procedure, and thereby set the exact frequency and the energy of the laser fiber so as to achieve the complete clearance. So it was again a prospective observational pilot study from December 2018 to April 2019. Total of 36 patients were included, those who have undergone either ureteroscopy, RIRS or PCNL. The morphological analysis that included the stone surface, shape and the color. This was actually recorded by the endoscopic view by the surgeon. And then accordingly, he has actually adjusted the laser setting like frequency, energy and pulse. And after the surgery, the stone was analyzed by the infrared spectroscopy. The primary endpoint was to see the correspondence between the endoscopic examination by the surgeon and the ex vivo stone analysis. And the secondary endpoint was the stone free rate at 6 months. So this is the results, because they have given the surgeon has given his impression of type of the stone basing upon the stone color and the shape, and accordingly he has actually adjusted his setting of the laser. So what they found in the results, there is a correspondence between the endoscopic examination and that of the after the stone analysis. 92% of correspondence between the endoscopic view examination and the stone analysis, and the stone free rate at 6 months were 82%. So what they're trying to tell, there is a good correspondence between the endoscopic assessment of the stone composition and ex vivo stone analysis, and accordingly adequate setting of the laser lithotripter based on the endoscopic appearance can be done, and sometimes it may help in deciding to change one approach like RIRS to PCNL if you feel like the stone is hard enough to do RIRS for such a long time. The third article was the treating upper tract urothelial carcinoma with Moses technology, the surgical and oncological outcome. It was from Israel. The Moses technology for Helmium laser was developed for the treatment of urolithiasis, and it enables the transfer of energy with 2 pulses of Holmium laser. The preclinical trials have demonstrated a different tissue effect compared to that of the standard Holmium laser. This is a study which was actually published in January 2018. This was on an in vivo porcine model to see for the effect of this Moses technology on the tissue. What they have done in this in vivo porcine model, they have actually tried to use the standard regular mode and the Moses mode to see if the Moses technology is actually causing less damage to the tissue or more damage to the tissue. As per this particular paper, there was no significant difference between the regular and Moses mode in terms of the coagulation margin and the tissue damage. And therefore, the Moses technology, they did not raise any safety concern as per the tissue ablation or tissue injury is concerned, because actually, if you go by the literature, this is more beneficial for the stone, but to see if it is actually safe for doing in upper tract TCC, like ablating the tumors. So this particular paper has shown actually it is safer. So to do this on their study, they have tried to actually evaluate the oncological and the surgical outcomes of Moses technology Holmium laser in treating upper tract urothelial cancers. It was again a retrospective review of patients who underwent endoscopic treatment of upper tract urothelial cancers between 2013 and 2019, and the intraoperative postoperative complication and the oncological outcomes in the form of local recurrence, local progression, and metastatic progression between patients treated with Moses technology and the standard Holmium laser were analyzed. So total of 59 patients, out of which 12 patients underwent with Moses technology, 47 with standard Holmium laser. The 12 patients, these patients have undergone total of 58 procedures, and 47 patients they have undergone 290 procedures. The median follow-up for Moses technology was 11 months, and that of the standard Holmium was 22 months. The local recurrence, if you see, it was 75% at 3 months for Moses technology, and 66% at 8.8 months for standard Holmium laser. However, they did not find any difference in the local progression or metastatic progression. But the ureteral stricture rate was 3 out of 12 patients, 25% in Moses technology. However, it was 0 in another out of 29 patients, but they didn't have data for another 28 patients. 18 patients, what happened to those patients? There is no data in this particular abstract. So the conclusion is endoscopic treatment of upper tract urothelial cancer using Moses technology. What they are trying to tell is oncologically efficient and higher ureteral strictures rate as compared to that of the available standard Holmium laser technique. The critical point is to comment about the recurrence, because this paper doesn't have any tumor characteristics. So what are the tumors, type of the tumors and the stage or grade of the tumors that has been included, has not been included in this particular abstract. So it's very, it's not easy or not, it's not actually advisable to comment on the recurrence or recurrence or progression without even knowing about the tumor characteristic. And the Moses technology obviously has higher local recurrence at shorter follow-up time, because it was 75% and the other one is 66%. That was around 9 months. So thank you all for the attention.
Thank you, Dr. Brishabhanu. You have done a wonderful job. These all the three abstracts I found were a little difficult to present actually, and you have presented them very concisely and very nicely. So now I'd like to have comments from Dr. Anil Shrestha, who's the primary expert for these three abstracts.
First of all, I would like to thank Dr. Dilip, Dr. Tanuj, and entire North Zone USI team for having me this evening. Regarding first abstract, the cost analysis of single-use versus reusable scopes, actually there are good numbers of studies recently are coming up, and there are good numbers of review articles recently published from Europe. There is an emergence of wide variety of single-use ureteroscopes recently, including from India, Indiscope, I guess, and different. These single-use scopes are different in terms of cost and hours of operation they give to the surgeons. And that these two factors, the cost of the individual scopes from different companies and hours of operation, that makes the cost analysis study very difficult, and these studies are non-representative for the centers other than where the study is being conducted. So actually, cost analysis of single use and even in reusable scopes are not very representative. And actually, we have lots of studies, but they are not very helpful for us. And there are so many factors that plays role when we talk about cost effectiveness of the flexible ureteroscopes, like surgical expertise. In experienced hands, I don't think there is much of problem with reusable scopes. There are lots of expertise here, and I trust that they agree with me that with some amount of surgical expertise, then we don't have problem with reusable scopes at all. And another factor that is very important is the number of cases we do in our center also plays role, whether you want to get reusable scopes or you want to get single-use scopes. Again, the cost of the scopes, single-use scopes are variable in different parts of countries and all over the world. So you may be paying little higher, I may be paying little less for the same scope from the same industry. So when we are reading articles of cost analysis of single-use scopes, then we have to be very careful and we have to be very vigilant, because it also makes difference when what sort of contract are you having with the suppliers also makes the difference. Another very important factor is a repair strategy of reusable scopes. In our part of the world, especially in my country, the repair of reusable scopes are very difficult. They have to send my scopes to Germany and then get repaired, which takes long time, very costly, and sometimes they just tell us that it is non-repairable and you have to buy another scope. So the cost effectiveness or cost analysis of flexible ureteroscopy and the study on this topic is very, very tricky actually. And the very good point of particularly this article is that they have mentioned that the higher number of the cases you do, the reusable scopes becomes more cost effective. That is proven thing, and I think that is a very important message from the first abstract. And
your voice is breaking, Dr. Anil. I think we lost him.
Yeah, we'll go ahead, sir. We can have comments from Anish Srivastava, sir, please, sir.
Right, Dilip. So I fully agree with regards to the first paper about the Flex XC. These are the practical things which you also might have encountered if you are using this one. Yes, and we had the an issue after I think 25 cases, and then of course it is being used in multiple hands in a teaching center, and then we got a message from Germany 2.5 months later that it is irreparable. So, and now we have recently started using the LithoView also. Very limited experience. And
Dr. Anil, we'll wait.
Yes.
Let Dr. Srivastava finish.
No, so that's what I was saying, that I think in due course of time, he has very analytically told us regarding the cost comparison and stuff, and I think we might be happier using the single use, so-called, depending on the hours they give. You can use them for in 3 cases or cases also. Depends on how much experience you have. If one can quickly do a case, then probably the one which we are using, LithoView, gives us 4 hours. So we can use it actually in 3 to 4 cases. So on paper it is single use. So the cost also, if divided amongst the patient, could be less. Let Anil complete.
Yes, sir. Yes, sir.
Yes.
Dr. Anil, please go ahead.
Am I audible?
Yes, yes, yes.
Thank you for heading up, Srivastav sir. Regarding second abstract regarding laser setting, I believe majority of endourologists, they change laser setting case specifically. Even in the same patient, changing laser settings intraoperatively is not uncommon, and depending upon the various factors, including stone factors, we keep on changing laser settings, and it is quite common, you know. And what I believe is, don't remain rigid regarding laser settings. You should not stick to fixed laser setting for a particular case. Even for the dusting laser mode, you have to change sometimes 0.2 joule to 0.8, sometimes 1 joule also, you know. What I have found is with the same laser setting, depending upon the upon your surgical skill, you can dust the stone with the same laser setting, and you can even fragment the stone with the same laser setting. So we should be changing our laser setting depending upon the stone characteristics, location, and other factors. So I think they have conducted pretty good study, and this is a nice study. And what amazes me is the correlation between endoscopic view and stone analysis is as high as 92%. It is quite fascinating. Can you hear me?
Yeah, we can hear you. Go ahead.
Regarding third article on Moses technology, Moses is actually pulse modulation of holmium laser introduced by Luminous, and it is only available in 120 watt laser from the Luminous. So unfortunately, Moses technology is not established. It is not being able to establish a firm position in the clinical practice because of the cost. It is very costly, and it is available only in single-use fiber, which is again not very practical in our subcontinent, Indian subcontinent, and possibly, as I mentioned, it is possible only in 120 watt laser from the Luminous. And recently, TFL is presenting very tough challenge to the Moses technology. That's why recently Moses is having a little hard time in establishment among the clinical urologists. And the problem with this Moses technology is again cost in our setup. And the good part of this abstract is that they have done it in upper tract TCC. But the shortcoming of this abstract is the number is very small. The number they have done only in 12 cases, and it's retrospective in design. Follow-up is very short, so that's why commenting on surgical and oncological outcome with follow-up of 3 to 11 months will be not very fair. And the problem, as Dr. Naik has mentioned, that the tumor characteristics was not very clear, whether it is a high grade, low grade, or the size of the tumor was not very clear. And very importantly, the laser setting was not very clear. Why the laser ureteric stricture rate was very high in Moses group? They should have mentioned the setting of the laser used for treatment of tumor in the lasers, ureters. So these are some shortcomings of the third abstract. Otherwise, it's a very good paper, but I would say vanishing technology. Moses is a vanishing technology because of the emergence of TFL in Thank you.
Any comments, sir, from SPRF, sir? Sir, you have to unmute yourself.
The only thing about the price part, yes, it's very important for us, and price changes from person to person, place to place, and company to company. Let the society take this issue again and again. With this, I think let's go to the next, Dr. Atul.
Yes, sir. Atul has been waiting with us patiently since 4 p.m. I was there and he was also there. I'm sorry, Atul, you are the last, but you have got the most important topic, which is RIRS versus PCNL.
Yes.
Atul,
Thank you, Norjon USI and Dr. Anup sir and Dr. Dilip for giving me opportunity. This is the slide is not.
You can see your slides. You can go ahead. Maybe the next
slide is not moving. Yes.
Yeah, go ahead.
The first paper is comparison between retrograde intrarenal surgery and percutaneous nephrolectomy in the management of 20 to 30 mm renal stone. It is by the Mrabiti M. et al. From Mohammed B. Military Hospital, Morocco. In this paper, the study population was the renal stone between 20 to 30 mm, which is compared the outcome of percutaneous nephrolithotripsy and IRS. As in outcome was compared is operative time, fluoroscopy time, hospitalized time, visual analog score at first post-op day, and stone-free rate. And it is the prospective randomized trial. Result of this study is that mean stone size was 24 mm and in the iris is 23 mm. Mean operative time is 82 and 83 minutes, and mainly stone free rate in single sitting is PCNL is 91.3%. and in IRS is 78.7%. And after auxiliary procedure, stone-free rate is 98% in PCNL and 97% and in IRS. And minor complication is more on PCNL than IRS. So conclusion of this study is the stone-free rate is PCNL more in PCNL than IRS in first sitting, but hospital history, fluoroscopy, time, and post-operative visual is more for the PCNL. As the EAU guideline also says, the percutaneous PCNL is indicated for renal stone more than 2 centimeter is a level of evidence is 1A, and it is strong recommendation also. And another paper is comparison of RIRS and PCNL for more than 2 centimeter. It is also says the stone free rate after first sitting is PCNL has a more stone free rate than RIRS. Next, it is comparison of PCNL and RIRS for management of 2 to 4 centimeter stones and match pair analysis. It also says the stone free rate was 73.5% for the RIRS group and 90.2% for PCNL group after a single procedure. And then abstract 2 is the comparison of RIRS, mini perc and ultra mini perc for lower calyceal stone between 1 and 2 centimeter. It is the randomized control or trial. The study was done in Vojni G group from the Italy, and it is safety and efficacy for 1 to 2 centimeter. Comparison by the RIRS group A, mini perc group B, and ultra mini perc group C. The outcome was stone free rate, retreatment rate, auxiliary procedure rate, and complication rate. And result of this study was that in the RAS total number of patients were 132, now of RAS in 44, mini PCL in 47, and ultimately ultimately PCL is 41. And mean stone size was 16 in RAS, 17 in mini PCNL, and ultimately PCNL 15. And important is stone free rate is 72% in RAS, mini PCNL in 82, and 78% in ultra mini PCNL. The complication is more in IRS than the mini ultra mini PCNL. The auxiliary and retreatment rate were similar, but RAS has more complication by this paper. Again, here guideline says is a lower pole stone, a lower pole 10 to 20 mm stone is favorable anatomy than ESW or Endourology, but in unfavorable anatomy, then first is Endourology, either RAS or mini PCNL or ultra mini PCNL. It is a systemic review meta-analysis by the Jiang H et al. By the minimal invasive PCNL and retrograde interrelationship, which favors the again PCNL then IRAS. Again, operative time and hospital is, this is the hospital A favor the IRAS, and complication is more on RAS. Again, this paper is standard PCNL, minimal invasive PCNL, and including mini PCNL and micro PCNL with RS separately. It is also systemic review of meta-analysis. It is also shows in the PCNL and RRS, it is favors the PCNL for the stone free rate, and complication rate is more in PCNL than the RAS, and hospital stay in less in RAS. This is a subgroup analysis with compared the mini PCNL versus RIRS. It is that operative time is more, or operative time is more than RAS than mini PCNL, but hospital stay is more in PCNL than RAS. Again, this paper concluded that the PCNL is associated with a higher stone-free rate at the expense of higher complication rate, blood loss, and admission time, and standard PCNL offers stone-free rate superior to those of RS. RS provides high stone-free rates than MIPP, and RS should be considered a standard therapy for stone less than 2 centimeter. The PCNL has a high stone-free rate as compared to RS, but a longer hospital stay, fluoroscopy time, and post-operative day in treating renal stone between 20 to 30 mm diameter. And RS mini PCNL is more effective than ultra mini PCNL to obtain a stone-free rate in lower calyceal stone 1 to 2 centimeter. And in the abstract 3, it is comparison of perioperative outcome between PCNL and flexible ureteroscopy in pediatric patient with kidney stone greater than 2 centimeter, in which they have included 32 patient, pediatric patient with renal stone more than 2 centimeter, and then PCNL is compared with RRS as in the PCNL 48 patients and RIS 84% is outcome in term of stone-free rate, complication, and intraoperative data. In this, in the results of this study says stone-free rate is more in flexible ureteroscopy. Complication is more on PCNL than RIS, and mid-hospitalized time is less in flexible URS, and operative duration is less in RIRS, and intraoperative perfusion is more in than PCNL. So stone recurrence rate is similar, but a special mention, this stone-free rate of flexible for underweight children was much lower compared to other weight status. The conclusion of the study is a flexible ureteroscopy, safe and effective procedure to treat pediatric kidney stone greater than 2 centimeter. However, high efficacy and safety were based on cases accumulated to reach the learning curve. And again, this article in published in Journal of Urology, PCNL versus RAS for large stone in pediatric patient randomized. It is the randomized control in which is total 30 patient, PCNL 21, RAS 22, stone size more than 2 cm. Stone free rate is more in PCNL than RAS in first setting. Radiation time, hospital stay and complications rate is more on PCNL versus RAS. Thank you so much for listening.
Thank you, Dr. Atul. You had presented all the abstract and summarized them very precisely. And now I'd like to have comments from Anish Srivastava, sir.
Okay, so the philosophy of management basically is on a tripod of the location of the stone, size, and the composition. If you see the three modalities of ESWL, PCNL, and RIRS. Now, in these today's presentation, ESWL has not been brought in. So we are left with PCNL versus RIRS. Now, we are all aware about the lower pole versus lower pole comparisons, and historically also, whenever the small lower pole stones were there, then only the ESWL and RIRS were promoted, and all larger stones, even larger than 1 centimeter, 1 to 2 centimeter, or 2 to 4, all were subjected to standard PCNL at that time, and now to mini PCNL. So the point is that out of these three studies, I find the second study because the best. Why? Because they are the only ones who have done this location-wise, looked at it location-wise. It's a lower pole stone with RIR and the other kinds of PCNL. I would suggest to other youngsters and others, whenever we are taking this study, we have to think a step further. Why? Because the more and more improved kind of flexible scopes are coming in the market every day. And we have got baskets which can actually take the stone from lower pole to pelvis or upper pole, where they can be more easily fragmented. We know about the infundibulopelvic angle. If the angle is, say, less than 30 or more than 30, again, it has an impact on ESWL as well as on RIRS. Then, how the stone free rate was compared, estimated and compared, that also is important. So, the point is that whenever we do such studies, we must define these factors also as an exclusion criteria. Whether a basket was used to relocate the stone, what were the angles like, and how was the SFR? If it is being done with the EAU, with the ultrasound, with the CT, that also is important. And I would say that even statistical method which you use for comparison is also important. I tell you one paper which we published in British Journal of Urology 2005, ESWL, lower pole with the size. Which is better? Means the clearance, is it better in 1 centimeter, 1 to 2 centimeter? And we use three statistical methods. And the paper was taken only because of this, because we said that this statistical method is better than the other one. So the point is that these are the things which one has to look at when you are critically analyzing the study. So the second one is good, the best out of it. In the first study, we have now come to a 3 centimeter point. Now, how this 3 centimeter thing has come? Generally, if you see all the old literature, it is less than 1, 1 to 2, 2 to 4. Now, with these, again, with these nuances and the advances with the flexibility rotation, the authors thought of another group, because 4 centimeter they thought with the RIRS is probably too big. Let us see with the 3 centimeter. So that is the philosophy behind that. And then finally, the third paper on the pediatric stone. He has presented it very well the message is very clear. I will only like to make a comment that when you do a perfusion of the volume of fluid which is used with the RIRS, it is anyway is more so in a pediatric patient under a high pressure, because excess sheath you cannot use practically in pediatric patient, and then the pressures will be very high as compared to the PCNL, where even if you are doing using irrigation, still lot of fluid can come back through the sheath. So those are the points. And finally, yes, all of us have seen in these studies that the stone-free rates were actually better with PCNL as compared to the RIRS.
Thank you, Anish sir. We can have a quick comments from both other experts, S.P. Yadav sir and Anil Shrestha sir.
See, my comment is only one. RIRS has a less clearance rate between 60 to 70%, and PCNL has a 90 to 95%. If you look at the Indian scenario where the practitioner are working or even the government job, for RIRS you have to go second time to completely clear it. We do not compare that one day extra or redo RIRS as compared to PCNL in the first time. What I mean to say that PCNL hospital stays more. This is the only point, hospital stays more. In RIRS, hospital stays less. Whereas the clearance rate is less and clearance rate is more in PCNL. So count that period also. If that period is counted, I personally feel the mini park or micro park may turn out to be a better choice, particularly for some selected inferior calyceal, bigger size, 3 centimeter size stones. In pediatric, I don't have much experience, but still have a hesitation in accepting the pressure with which RIRS is being used in a pediatric age group. Dr. Srivastava has already commented. And with this, thank you, Dr. Dilip. Thank you, Noor. Thank you, the President and Secretary of the Noor. Thank you very much.
Thank you, sir. Anil Shrestha sir, one final comment.
Yes, regarding comparison of PCNL and RIRS for 2 to 3 centimeter stone, I think guideline has clearly mentioned that PCNL has a better outcome when the stone size is more than 2 centimeters. So I think the study design itself has some shortcomings. So definitely in the stone size between 2 to 3 centimeters, PCNL will have better outcomes, as Dr. Yadav has correctly mentioned that it will have less auxiliary procedures in comparison to RIRS. So I think we have to stick to the guidelines. The guidelines are not made without any evidence. So if we stick to stone size less than 2 centimeters for RIRS, I think we can have very good stone clearance rate with RIRS. And regarding lower pole stone, as Srivastava sir has correctly mentioned, that the current modern ureteroscopes have very good deflections, so we can reach to lower pole very easily without much difficulty. Up to 2 centimeter, if you have good laser, good visuals, then RIRS is a very attractive options for even for lower pole stone. Thank you.
Thank you, Shrestha sir. So with this, we are finishing this RIRS session also, and I would like to thank our experts, Anish Srivastava sir, Anil Shrestha sir, and S.P. Yadav sir, who have given their time for us and their very nice expert comments. And I would also thank Sunil Gupta sir, who has been sitting all through the night watching us. And that's all. I would thank Anup sir and Amlesh sir for giving us the opportunity. It was a very nice program and very nice concept.
I would just like to make one comment.
Yes, sir. Yes, sir.
So the last 3 papers, there has been a comparison between RIR and PCNL. Whereas practically all patients who would have a small stone would have ESWL first. And only some of them, most of them would have ESWL without a stent. Some of them may have ESWL with a stent. And before RIR, we always put in a stent. That is, So therefore, this comparison of RIR with PCNL is actually not truly a practical comparison. We should include the arm of ESWL also. And practically, RIR is for residual stone after ESWL.
Thank you, sir. Thank you for your comments. So now I would like to finish this session. I would also thank all the speakers who have worked very hard to, to go through the abstracts and make them into nice small slides and present them in such a small short time. That was a commendable job by all the speakers. And with this, I would hand over to Tanuj for the closing remarks and to Anup sir as well.
I would just like to quickly thank Dr. Amlesh Seth sir and Dr. Anup Kumar on myself and Dr. Dilip's behalf for letting us convene this program. And thank you so much to all the experts, especially the international faculty, Dr. Anil, Dr. Loh, and Dr. Amit sir. And thanks to all the speakers for concise presentation. And sorry for exceeding the time a bit. Over to you, Dr. Anup sir, please.
Yeah, so now this comes to the conclusion of this wonderful program. And as always, this program was attended by more than 500 delegates on various platforms. So that speaks about the success of this program. A huge round of applause for our coordinators, conveners for this program, Dr. Tanuj and Dr. Dilip, for doing the hard work, selecting the abstracts. And of course, all our young speakers, we are proud of them. They have shown their talent. We are all seeing how talented they are. And our seniors have appreciated their efforts. And of course, our experts are always there. For the last 3.5 hours, they're sitting there, giving their comments and supervising and giving the guidance. So that's what our society needs. The seniors giving way to the juniors, giving their guidance and giving their supervision to them. And I think this is how we are going to go forward. And I want to also thank Mr. Navneet and his team for his effort, all the efforts he has put for this program. Thank you very much, all international faculties and the national faculties. Any last word Dr. Amlesh Seth wants to give, he can conclude.
So thank you very much. Thank you, everybody. We have already exceeded the time, and
Yes,
it
sir.
has been a very good program. Thank you. And good
Thank
night,
you.
everybody.
Thank
you,
you.
sir. We'll finish here. Thank you.
Yeah. Thank you. Good night. Good night.
Good night. Good night.
Night.